Hello and good evening, dear students. I am Dr. Ruchi Raj, your prosthodontics mentor at DBMCI MDS, and I welcome you all to this mega recall session, day 2 of NEET MDS 2026 paper. First and foremost, what are your first thoughts on your exam? How was it? And how was your paper? What are your reviews for it? Let me know in the comment box. I have the YouTube link here with me open, and I can see all of your messages in the chat box. We will keep it as an interactive session. Very good evening to all our students, and I hope your paper went well. I have some initial reviews and feedback from our student, but I'm eager to listen to all of you. What are your thoughts? How did the paper go for you? How was Prostho specifically for you? I even ran a small poll via Instagram to see what was the general feedback of students, whether it was easy, it was moderate, or it was tough. And about 50% of students, this is the vote ratio. They voted that it was a moderate paper and a moderately tough paper. That is the general feedback that I got from students, right? Even a lot of you over here are commenting it is a moderate paper, it was tough, it was a very tough paper. So before we start with the actual recall of question, I would like to touch or discuss slightly upon what exactly the paper was, according to me, what I feel about the paper, and how can we tackle and best give our performance in papers like these, and what helps in exams like these, right? So I was anticipating that tough, 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 very tough. These are the comments that I'm going to get in the chat box. On the first outlook, it will look like a tough paper, but if you closely look and see the questions, it's a very conceptual paper. Indeed, or in fact, it's lengthy, which makes it difficult for you to solve in that short span of time. And if you're not focused, if your focus is not on point, and if your concepts are not clear, you may not be able to solve it in your first read. And when you take more time, your time for the subsequent questions will be then less, and chances of making error that way increases. This is how the paper looks tough to you, wherein in fact it may be a moderate paper. I'm not saying it's not an easy paper. It's a very well conceptually created, combining all the clinical sciences here. There were very less fact-based questions. There are fact-based questions, but lesser. They are more clinical questions that integrate the concepts very beautifully. So if you have watched our recordings or if you have attended live classes and understood these concepts, then it will be a moderate paper for you where you read the question, and then if your focus is on point and you're attentive, you will be able to solve it in that one go over there, and then the length of the paper would be such that will balance out against your time. Otherwise, if you keep rereading the question, then what happens is you dedicate more time on that question, and then eventually your time for other question gets less. Is this what you feel or what you felt in the exam? Let me know. This is what I feel after looking at the paper. So I'll call it a moderately tough paper, but the good part is we have taught almost everything. Then the second thing is what we always predict, which are the PYTs. The questions have come from those topics only. These are all of the topics that we have been repeatedly stressing upon. Third, and the most important thing which I would like to highlight is, even you would be able to see it in the screenshots shared, all of these things are mentioned in our notes. They are there in our live classes. They are there in our recordings also. So if you are attentive with these things and you have solved the Q bank, you don't need anything else, right? So this is how these kind of papers differentiate students whose concepts are clear with students who find a little difficulty in understanding these concepts and may require more revisions, right? Am I right or not? Let me know in the comment box, right? So yes, like what Saurabh is saying, secondary ka time nahi mila, so error is possible, right? That is how these kind of papers are tricky to solve. So concepts should be on point, and this is something that we always have been stressing on. Concepts should be on point, then and then only you solve these kinds of paper. Otherwise, it breaks your morale. most importantly, other things also. The last GTs, the INI GTs that specifically for Prosto I had made, it had questions on your surveying tools. It had questions on a lot of these topics that are there in your NEET 2026. So even if you have done these GTs, you should be able to solve the NEET MDS 2026 paper. So whatever we have been stressing all, solve your GTs, solve the Q bank, read notes. If you have done this, you would be able to easily sail through this paper. That is what my opinion is. Now, let us solve the first question over here, right? Archon articulator is characterized by what? It's a fact-based question. Condylar element in the upper membrane, condylar analog in the lower membrane, condylar analog in the upper membrane, and condylar fossa in the lower membrane. The beauty of Archon articulator is it exactly mimics the temporomandibular joint. So in a temporomandibular joint, condyle is in the lower member, fossa is in the upper member, as we have mentioned in the notes over here also. In an Archon articulator, condyle is in the lower member, fossa is in the upper member. Now let us come to the options. Condylar element in the upper membrane is in fact wrong. Condylar analog in the lower member is our answer. But as I've always said, you have to cancel out other options. Condylar analog in the upper member, no, again wrong. And condylar fossa in the lower member is again wrong. Fossa is always in the upper member, right? So correct answer here is condylar analog in the lower member. Students, were you able to solve this? Right? Condylar analog is in the lower membrane. The condyle is also called the condylar analog, is in the lower membrane, and the fossa is in the upper membrane. So B is your answer, right? I'll come to the cutoff. What, according to me, what I feel is the cutoff at the end of this session. A lot of students are asking about cutoff. Let me come to it at the end of it. However, Dr. Imani can contribute better to the overall cutoff because she discusses the paper analysis. Still, I'll come to it at the end of it, right? So question 1, answer is B. Now, where will you fall or make a mistake here? The words analog and element. You will make a mistake over here in reading, get confused and mark it wrong. Although all of you know and we have read Archon and non-Archon. Archon was given by Bergstrom. It is very clearly there in our notes, discussed probably 100 times. This is a straightforward question. Let's come to question number 2. A cast was showing Kennedy class 1 situation. A major connector was shown and then it was asked the indication of it. The major connector was present on the labial side. It was a mandibular cast, right? So options were, what is the indication of major connector displayed over here? Periodontally weakened teeth, lingually inclined teeth, deep lingual vestibule, and shallow lingual vestibule. Again, let's come to our notes over here. Labial bar was shown in the image and the indications are very clearly shown over here. All 3 indications are written. So let us understand the question. A labial bar in mandible is always constructed when lingual side you cannot place the major connector. Only then you come as a last resort on the labial bar. In what situations can't you go on the lingual side? Very large inoperable torus mentioned in our notes over here. First point only. Second, you have severe lingually tilted anterior teeth that you don't get a path of insertion for your major connector lingually, then that is the second option. Third option, which we have specifically mentioned in the notes, and if you have read this, it will 100% give you the correct answer in exam. Shallow lingual sulcus alone cannot be the indication. To have a shallow lingual sulcus with a very active floor of the mouth is an indication. Just shallow lingual vestibule, which was one of the options, is not correct. It is in fact incomplete. You should have a shallow lingual vestibule plus a very active floor of the mouth, which will not allow you placing any lingual kind of a major connector. Only then you go on the labial side. So if you have read this from the notes, you can very easily come to the correct conclusion that the answer is B, lingually inclined teeth. So correct answer for second question is option number B. This was again very clearly mentioned in our notes. Now, let me clarify in option number D. Shallow lingual vestibule is an indication for sublingual bar also, 6 millimeters of height. But in what cases can we go for a labial bar? Where the floor of the mouth is so active, it does not allow you to place any lingual major connector, which is mentioned here clearly in our notes also. So this is how you should be able to differentiate here. This is the beauty of this paper, right? The paper that was there on Saturday. It integrated concepts very clearly. And if you have understood what exactly are indications, only then you'll be able to solve them. Otherwise, despite knowing the topics, you won't be able to solve them. That was the kind of paper. It's a beautifully constructed paper. It segregates someone who has good knowledge from someone who has missed a few revisions here and there, right? So students, the correct answer here is option number B, lingually inclined teeth, right? Deep lingual vestibule cannot be an indication. Periodontally weakened teeth. In fact, both of these are your conditions where you give a lingual major connector. In here, you give a linguoplate, and in deep lingual vestibule, you can very easily construct a lingual bar also, right? So that is how second question is. Now, question number 3. While making anterior lingual sulcus border molding and impression, which action records the thickness of the sulcus? Now, let us come to your chat questions also. Just a second. Okay. While making anterior lingual sulcus border molding and impression, which action records thickness of the sulcus or the width of the sulcus? The meaning of the question was to ask how to record the width of anterior lingual sulcus. Is it by protrusion of tongue? Is it by tongue touching at the anterior hard palate? Is it by either saying the sound F, F or K? And is it by retrusion of tongue, right? So correct answer here is option number B, tongue touching the anterior hard palate. Now let us come to our notes again. All of our DBMCI students who have attended live classes with me, who have watched my recordings, every time we come to border molding, we start doing these exercises. If you are in live, we are doing simultaneously. And I ask you, take your tongue, protrude it, take your tongue, wipe your lips, take your tongue, touch it to the anterior part of the palate. So let us all do it over here. Take your tongue and touch it to the anterior part of the palate as if you're pushing the anterior palate. You will see fanning of your tongue. It will spread out like this, and the width of the anterior lingual sulcus can be recorded. When you wipe your lips with the tongue and you protrude it, you will see that when the tongue comes out, floor of the mouth is elevated and height of anterior lingual sulcus is recorded. There are two components of sulcus always. There is a height and there's a thickness. Both of them are recorded in border molding. When you protrude your tongue and you wipe your lips, at that time, notice it, do it simultaneously. When you protrude your tongue, when you wipe your lips, floor of the mouth is elevated, you are recording the height of the sulcus. But the question meant to ask you the thickness or the width of the flange. So when you push at the anterior part of the palate, at that point of time, you will have fanning or spreading of the tongue, and it will record the width of the sulcus at that point. So let us come here, see, very clearly it is written, when you protrude or wipe the lips, length or height of sulcus is recorded. And when you push the tongue against anterior palate, width of it is recorded. So, question number 3, correct answer is B, tongue touching anterior hard palate. All students of DBMCI who have attended classes with me, if you're watching right now, let me know in the comments. Do you remember doing this exercise along with me in live classes and even in recordings also? And now someone is saying, yeah, Divya is saying, I forgot the notes, then I moved my tongue sitting there and then I attempted the answer, right? So that is how this is. And some students are asking to fasten up the session. Students, we have to take it up with some little explanation here and there. So please bear with me, but the session will be done in 30-45 minutes. Okay, so this is question number 3. Now, I'll give you one piece of little disclaimer also. Whenever we take up these recall sessions, these are of course recall questions. So some things may be here and there. help us refine our questions better so they are ready for you before your next exam. If you have any suggestions, you can always leave them in the chat box also. We explain the questions to you so that you are guarded with all of the information regarding this particular topic also. And if at all it was slightly different in the exam, and if it is repeated in your next INI, you can attempt it with the correct answer yourself, right? So that is the reason I'm explaining everything. Now let us come to question number 4. Which of these does not show interference contact in dentate patients? So the question meant to ask which of these sides do not show you any interferences? Centric, working side, non-working side, maximum intercuspation. What will not show you any interferences? So in any dentate patient, there are always interferences or occlusal interferences seen on the working side also, on the non-working side also, and even in centric also. But in MIP, there are no interferences. So the correct answer would be maximum intercuspation. If you have better refined version of any of these questions, you can always share it with me on our chat boxes, and we will be more happy to refine and get it better to you before your next exams. Right? Now, according to pleasure, it's a new kind of a question taken from, although we have learned all of these pleasure curve and everything in occlusion, but it has been slightly modified for the exam. So according to pleasure for class 2 ridge relation, which type of occlusion is needed? So students, do you remember your pleasure curve like this, right? So pleasure gave a modification of occlusion that instead of giving you a standard straightforward balanced occlusion, we do some modification in teeth arrangement so that stability of lower denture can be improved. And what was that modification? Premolars are inclined slightly buccally, maxillary first molar is horizontal, and then your maxillary second molar is slightly lingually inclined. So correct answer here is option number C, premolars buccal inclined, maxillary first molar horizontal, and second molar is lingually inclined. So first premolar will be slightly buccally inclined, then this, and then this. That forms your pleasure curve. So other options were balanced occlusion, a reverse of this in option number B, and disocclusion, but they are not applicable to here. Now, why is it not, they have not given anything specifically that lower denture has loss of stability. They have written class 2. So you have to figure out and understand that in a class 2 ridge relationship, when there is a retruded mandible, chances of loss of stability of denture are there. And loss of stability means you have to modify your occlusion. So you have to figure out what kind of teeth arrangement or occlusion we need to do, and their pleasure curve or pleasures scheme of occlusion can be incorporated, which is option number C over here. So this is how integrated and all of the clinical conceptual questions were there. Right? So correct answer here is question number 5, option number C. Now, a lot of students are saying prostho, wrong. So did you all got all of these wrong? Just let me know in the comment box, right? Now, question number 6. A diagram or an image similar to this was probably there in the exam and asking you a survey line and clasp. Now, here I'll give you a quick disclaimer. I have not seen the photo. So I'll explain you both sides and I'll explain what I feel is probably the answer, right? So identify the survey line and the clasp indicated for it. A diagonal survey line and Akers clasp, diagonal survey line and reverse circlet, and medium survey line and Akers and medium survey line and reverse circlet were in the options. Now, basic funda here in your surveying is what? You have, basic funda here is you have a vertical line like this, and your near zone is the one that is adjacent to the edentulous area, far zone is the one away from the edentulous area. Now, if you have a survey line in the occlusal third like this in near and far zone, it is a high survey line. If you have a survey line coming from the middle third in the near zone and to the cervical third in the far zone, then it is what? A medium survey line or a typical survey line. If you have it in the cervical third in both of the zones, it is a low survey line. And what do you have now? For example, the last one is what? Diagonal. It starts from the occlusion and comes to the cervical like this. right? It was a hand-drawn diagram. That is a diagonal survey line. So the feedback that I've gotten is there was a diagonal survey line that was seen in the image. It was a distal extension case-like situation. So in a diagonal survey line and a distal extension case, the indication then becomes a reverse circlet clasp, right? So reverse circlet clasp, option B is your correct answer. All those who have understood bottle opener principle with me would be able to solve this question. Bottle opener principle, we have discussed thoroughly so many times in our YouTube sessions, in our GTs, in our live classes, recordings, it is there in our notes as well, right? So if you have understood this concept, just by looking at the image, you would be able to figure out we are supposed to use reverse circlet clasp over here. Beauty of this question is, if you know either of one, you would be able to take a guesswork on the other thing. If you're able to identify the survey line, you would be able to take a guesswork on the clasp also, right? So why not Akers clasp? In such distal extension, we don't do Akers clasp. That is what bottle opener principle is. And the answer for this is then reverse circlet clasp. So this is on the basis of the feedback that I've given, I've received from students. Again, I have not seen the image, but I've tried to explain all of the case scenarios over here. Now, a lot of students feel it could have been medium survey line. If it was a medium survey line, then again, in a medium survey line, generally we give Akers clasp. We do not advise or go for a reverse circlet clasp. Usual indications are what? When we have a high survey line, we go for Rottweiler clasp. When we have a medium survey line, we go for a circumferential Akers clasp. When we have a diagonal survey line, we generally go for reverse circlet. When we have a low survey line, we go for your I-bar kind of an assembly. Now, seeing it was a distal extension case like this, indication becomes a reverse circlet clasp. That is why I am trying to decipher or understand that it would have been a diagonal survey line, not a medium survey line. Also, it is very difficult to figure out between both of them. So this is what I'm deciphering and putting as my answer over here, right? So diagonal survey line and a reverse circlet clasp on the basis of the case. That is my final answer over here. Now, question number 7, again from the same topic. Now, this kind of paper has one more pattern of NB which it generally follows. Questions coming from the same topics, 2-3 questions coming from same topic. So reverse circlet possibly was there in the previous one also. It is there over here also. Identify the type of clasp in this distal extension RPD. You can see a mesio-occlusal rest over here and an engagement of the distal undercut. Students, can you let me know what it was? It is a reverse circlet clasp. And in fact, I'm very happy to share the same image is there in our notes also. The same image is there in our notes also. Reverse circlet clasp originating from your mesio-occlusal rest, engaging the distofacial undercut. So if you have understood the entire logic of bottle opener principle and indications of clasp with me in any of these recordings or live, these all questions would then be easier for you. Yes or no, students? Right? So reverse circlet clasp is the correct answer here. And yes, some students are definitely saying that it was medium or diagonal. It was difficult to figure out. Even I am giving you that clarification also. On the basis of assumption of the total scenario, if it's a distal extension, you can't give your Akers clasp. It cannot be. Otherwise, the clasp will tip into the edentulous space, right? So in that scenario, obviously reverse circlet is the indication. And where do you give reverse circlet? In a diagonal survey line. Reverse circlet is generally not given for a medium survey line. That is why we have come to that particular answer, right? So that is the previous question. This is a straightforward reverse circlet clasp, again shown in our notes also, right? Now, if an operator makes more than 20 degrees taper during tooth preparation, what would be affected? Increase in resistance, decrease retention, increase retention, decrease structural durability. Now, here I have one suggestion or something that I specifically got as a feedback from students is the main thing which is affected by increase of taper is retention form is not affected primarily. Resistance form is affected. As soon as your taper increases, primarily first resistance form is affected, it reduces. However, that was not the option. So then the next best option is decrease your retention. Option number B, decrease in retention occurs. That is option number B. Again, this has been written in our notes. As you can see over here, When the taper increases, retention decreases. It is very clearly the Jorgensen article, along with the image of Jorgensen article. This is also a point in FPD. From the entire topic of FPD, actually, this is one sector or area, resistance and retention form, where I stress upon a lot, where I pause, slow down my class a little bit and teach you patiently. This is exactly that only. As your taper increases, retention reduces. Exactly the same thing has been asked in exam. Out of all of these options, question number 8, option number B is the correct answer. Structural durability has no role over here, and resistance does have a role, but the correct option was not given. Now, let's come to question number 9. In a patient with Armani class 2, what factor should be considered most while fabricating a prosthesis? So these are all different factors that affect prosthesis construction, but we have to see what can be considered the most while fabricating a prosthesis. So, is it tissue coverage? Is it force distribution on remaining teeth along their long axis? Is it aesthetics or minimum extension? Armani classification, we have given it as one of the most important previous year topics also in our list, also mentioned in our notes. And this is a slightly conceptual question originating from that classification. As you can see over here, this is a class 2 Armani case, and it is a unilateral defect or a unilateral resection with the segment of teeth on other side. And its main concern is similar to your RPD over here. Treat it like an RPD. There's a tendency of tipping or torquing of the RPD or prosthesis towards the defect site. So if you do not actually align the forces and design it better, there's a chance that there will be non-axial forces on the abutment teeth, and eventually there will be detrimental forces on them. So force distribution becomes one of the most important factors. Of course, span of the prosthesis is important, coverage is important, aesthetics is also important. But when designing this case, most important will be direction of force along the long axis of abutment teeth so that there are no excessive lateral forces, because this RPD will have a natural tendency to tip or torque. That is why you have to construct it in this fashion, right? So question 9 is this. Now, question number 10. During an implant surgery in mandibular premolar region, patient complains of numbness and tingling in lower lip immediately as implant was placed. Most important point was immediately as implant was placed. What should be done next? So we are assuming mental nerve injury since canine premolar region is mentioned in the question. And the good point which is written in the question is immediate tingling and numbness is as soon as implant is placed, patient is experiencing immediate tingling as well as numbness. So what do? You remove the implant immediately. You cannot wait and watch because these are clear signs of nerve compression. So you cannot wait and watch. There is no role of analgesics and antibiotics over here. You decompress it by removing the implant immediately, right? And you do not proceed ahead with the implant osteotomy or even the surgery here. So correct answer is option number A, removal of implant immediately. It solely depends on this word here, immediately as the implant was placed. So that is question 10. Now, question 11, again a good question from implant. An implant and abutment junction should be favorable in what manner for osseointegration and minimum micro leakage? So it is talking about the junction of implant and abutment. Now, out of the range of previous year topics, earlier they used to come on platform switching a lot. That is also related with implant abutment junction. This time they've come to something else. So the topic background remains the same only. They are just picking different branches out of it. Options were implant abutment junction should be cold welded, it should be external hex, it should be cement retained, or crown should be longer than implant. Now, implant abutment junction, our ideal requirement is there should be minimum movement and there should be minimum micro leakage at this joint, right? So when it is external hex, it has in fact much more movement than internal hex. So it is not advisable. Implant crown should be cement treated. That is a crown and the abutment junction. It has no relation with implant abutment junction. Crown should be longer than implant is in fact biomechanically not favorable. Cold welding, a good stable joint of implant and abutment. That is your correct answer. So option number A, implant abutment junction should be cold welded, should be your correct answer, 100% over here. Now, question number 12. Impression technique using this tray was given by whom? Hindle, Boucher, Rudd and Morrow, or Stewart? Exactly same image present in our notes. It is Hindle's technique. It is one of the dual impression techniques. It's a modification of McLean's technique. Holes are constructed in tray for pushing the fingers through the holes and applying digital pressure. Image is there in our notes. We have discussed this in our classes also. Again, something, if you have read the notes, if you have attended classes, you should be able to easily figure it out. So this is a fact-based question. This is a Hindle's technique. It is a modification of McLean's technique here. Now, in an implant crown, to prevent screw loosening, what is most important? Impression, occlusion, aesthetics. I'm missing out on the fourth option. Students, if you can help me with the fourth option, that would be great. So, for an implant crown, to prevent screw loosening, what is most important? The difference between implant and tooth is implant lacks PDL, so there's no cushioning effect. All of the forces that are there on the crown are directly transferred to the implant. And if they are non-axial, they are then loaded onto the different components. So any non-axial force loading on the implant abutment screw junction may in future lead to screw loosening. And this forces are determined by the occlusion. So impression is important for the fit of the crown. Aesthetics is important for satisfaction of the patient or overall appearance. But at the end of the day, occlusion is most important for your forces acting onto the implant and the crown and the long-term stability of the crown implant also. So occlusion is the correct answer, right? So 13th question. Option number B, occlusion, is the correct answer. Now, question number 4. Question had something mentioned like identify what is present on the left side of the screen, and there's a complete array of surveying tools. This was there in our last GT before the exam, discussing the process of surveying. It was marking something on the analyzing rod. So the options were analyzing rod, undercut gauge, carbon marker, and paralleling pin or paralleling tool, something like that. But the marking was there on the analyzing rod present on the left of the screen. So answer is analyzing rod. It's a simple image-based question. You do surveying with your analyzing rod. You in fact begin your surveying with it, right? So 14th question, correct option is option number A. Right? This is in fact even present in our notes also. This is the analyzing rod and these are the different surveying tools that are used, right? With this, we come to an end of this discussion and recall of NEET MDS 2026. I'll quickly have a look at your suggestions and even your queries in the chat box. If there are anything, we can take it up. Otherwise, we can start with the next subject. Okay, so a mixed bag of feedback here and there. And we are, of course, always available on Telegram and all of the other mediums where students can connect with us and ask doubts. As always, I will always stress on one thing. Read your PYQs, read your notes, do the question bank very well, then and understand the concepts through the live and recorded classes. Of course, then all of this becomes easy for you. Otherwise, it's a little tricky paper. Topics are the same, the questions are tricky. With this, we bring an end to this particular recall. The next subject in line is Orthodontics by Dr. Kunal Agrawal. Thank you.
Hi, Dr. Ruchi. I just heard you took my name. So just a quick hi to all of you and to Dr. Ruchi particularly. All right. Hi, my dear students. Good evening. This is Dr. Kunal Agrawal, your original guru for the subject of orthodontics at DBMCI MDS. So I had a I had a mixed review about the exam. I was talking to different students, and few of them said that the question level was okay types. Few of them said that the question was little difficult, and there was one unanimous, feedback about the exam paper that it was a bit lengthy. I suppose that is true for all the subjects, not only orthodontics particularly. It was true for all the subjects, right? So yes, it was lengthy, as I can see. One second. One second, I'll just open up the link. Yes, here it is. Okay. So now I have the link in front of me as well. So yes, it was lengthy paper. And also, there were hardly any direct pickups. There was hardly any objective question. Almost all the questions were application based. In one way or the other, the complete syllabus, the complete holistic understanding of the subject is important. As I've been telling all of my students during my lecture, during my live lectures, during my recording lectures, during the discussions of GTs, SGTs, PCTs, everything. So I made it a point. This trend has been, I've seen this trend since last 2, 3 years, since the time I joined DBMCI, that there was a gradual shift towards asking application-based questions in orthodontics particularly. And I'm sure that must be the trend in other subjects as well. So I made it a point to create certain questions in different GTs which were more clinically oriented. You must have observed, there was hardly any one-liner in any of the GT exams. So I purposefully avoided using one-liner questions in the exams. So I gave my best to make a complete integrated understanding of the subject in the form of clinical applications. All right. So with that, let's start with the very first question. Yeah, ortho was difficult. Anushka is saying it was lengthy and tricky. Yes, of course it was tricky. I have seen a few questions, they were a little tricky. Yes. Ortho was very difficult, but quad helix and twin block was easy because they were image-based questions. It was very easy for you to identify both of them, right? So let's start with the very first question. A patient is planned for mandibular widening by distraction osteogenesis. So this was an overlapping question. So I'm sure Dr. Himani must have taken this question as well. So I'll be talking about the orthodontic aspect. She must have talked to you about the oral surgical aspects. The surgeon needs help from the orthodontist for pre-surgical movement of the lower anterior teeth particularly. Fixed orthodontic therapy is planned for divergence of roots of the mandibular incisors. So that's why they need the help of an orthodontist, right? This is done with the purpose of, first option, intrusion of incisors to prevent hindrance and activation of distraction device, creating enough bone on both sides of osteotomy for good periodontal health, for correction of crowding in the mandibular arch, and for causing an increase in the arch length. So correction of crowding the mandibular arch does not make any sense because we will be doing orthodontic treatment for sure for that purpose particularly. But here the question has been integrated with distraction osteogenesis. The question is asking what do we need to do extra that will facilitate the surgeon performing distraction osteogenesis without any untoward circumstance, without any undesirable side effects. And for causing increase in arch length, again, it doesn't make any sense. Intrusion of incisors, again, it does not make any sense because we are not actually intruding the incisors. We don't want intrusion of incisors while distraction. We want to create enough bone on both sides of the osteotomy for good periodontal health. And I have particularly, again, I'll repeat myself, I'm going to reiterate myself. Orthodontics is a clinical subject. It's a very lengthy clinical subject. When you talk about a stomatognathic system, it's not only just the teeth and the jaws. It includes the teeth, the jaws, of course. It includes the temporomandibular joint. It includes the functional spaces of the cranium, the maxillary sinus, the oral cavity, the tongue, the pharyngeal space, the hyoid bone, the suprahyoid group of muscles, even the cervical vertebrae, C2, C3, C4 particularly. right? So everything together makes up the stomatognathic system. So I have talked about this particular concept in the chapter on retention and relapse in the notes, as you can see on the screen of your devices. The chapter is retention and relapse, and I want to I want to make myself clear that I have particularly talked about Raleigh-Williams keys to eliminate lower incisor retention. In that, one of the key was to spread the apices of the lower anteriors distally. This is what I'm talking about, the second figure. This is the second key, that the apices of the lower incisor should be spread distally. Again, this is done with the purpose to separate the roots from each other, so that we don't want imbrication. Whenever the roots are together, they are very congested. That term is called imbrication, right? We have talked about that as well. So we want roots of the teeth to separate, to diverge, so that when the oral surgeon makes a cut, when the oral surgeon makes an osteotomy cut for initiating a distractional osteogenesis device, there will not be any iatrogenic side effect to the teeth. We don't want any intentional damage to the roots of the teeth, right? That can happen while osteotomy cut, which can render the tooth non-vital and other problems also. So we want to minimize that complication by spreading the roots distally to create good space, to create good interdental bone between them, so that the surgeon will have adequate bone to give a osteotomy cut for distractional osteogenesis. Okay, so this is one. And also, I have talked about distractional osteogenesis in the chapter on major surgical procedures. Here, I have shown this with the help of a diagram. This diagram has been taken from the textbook of Contemporary Orthodontics by William R. Prophet. You can see here that the extent of constriction of the mandible is more than the extent of expansion of the mandible. But however, expansion of the mandible is now possible by distraction osteogenesis devices. I have also told many times earlier that any expansion in the intercanine width, particularly in the mandible, tends to remain unstable in the long run. But with increased evidence, with increased clinical backing, nowadays, whenever expansion has been done by distractional osteogenesis device, it tends to remain constant. It tends to remain stable for a longer period of time. Okay, so both of these things we have talked about in the notes on in two different chapters. So this is the summary of the question. Orthodontic divergence of incisor roots is done to increase the interarticular space, as I just said, ensure sufficient bone is present on either side of the planned osteotomy, and protect the periodontal structures and tooth vitality during and after the procedure. So I mentioned all the 3 points in my discussion right now. The goal is not intrusion, crowding correction, or increasing arsening directly, but rather to create a safe and biologically safe surgical site for the surgeon to do his work. Okay? So, question number 1, the correct answer will be option number 2, option number B. Next question. The video shown below is activation of an expansion appliance. Which of these will confirm skeletal movement achieved by it? I wish I could have shown you the video. I don't have the video right now. Anyways, the video was the orthodontist was holding an appliance in his hand and he was putting a key and activating it. Right? One second. I have a few questions. Question might be moderate. Yeah. Okay, something increased transfer, pacing gradient. Okay. Ortho nodes are too vast. Okay. It was stripping of the incisors to prevent hindrance during the Sandalwood Music is saying, sir, we know you explained everything. Just say the answers, please. But you have to bear with me. It's going to take some time. I'll be here for the next around 30-35 minutes. Okay? Okay. Fine. We do not need explanation. All right. Fine. Okay. Fine. So the video shown below is activation of an expansion appliance. Which of these will confirm skeletal movement achieved by it? So the correct answer will be creation of midline diastema. Again, I have talked about this in the chapter on arch expansion. You can see in the figure, at the beginning of rapid expansion and at the end of the period of rapid expansion, there is opening up of the midline space, midline diastema after the activation. So this is a clinical sign. This is a clinical sign that the expansion has taken place as desired. Medicos is saying, I think DBMCI need ortho faculty change. All right, fine. I'll take your feedback. Thank you so much. Now, which surprisal is used to overcome the limitation of FMA angle, SNA angle, SNB angle, or ANB angle? Okay, so next option is Saif Akhtar is saying, क्या आदमी है ये भाई? भाई क्या हो गया तेरे को? What happened? If you don't like me, you can very well leave the chat, na? You can very well leave the, you can go do whatever you want to do. But why are you abusing here? So which surprisal used to overcome the limitation of? It is A and B angle. This also I've talked about. This also I've talked about in the chapter on cephalometrics by which surprisal. Okay? So it is developed by Alexander Jacobson and it is used to overcome the shortcomings of A and B angle. Okay, so you just want answers fast forward. Okay, fine. 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 I think you guys are talking among yourselves. Don't be rude. Exam बुरा गया तो गुस्सा क्यों निकाल रहा है भाई? Okay, fine. Please leave if you don't want to listen. Yeah, that's what I'm saying. Huh? Please leave if you don't want to listen. You can come back later on. A patient presents with class 3 malocclusion due to maxillary deficiency. Orthodontist planned a face mask and noticed clockwise rotation of the maxilla and frontal lengthening of the lower face. What should be done to prevent this? Okay, so we have the clinical situation here. We have maxillary deficiency. We have clockwise rotation of the maxilla and frontal lengthening of the lower face. So the LAFH is also increased. Okay, this is also increased. So what should be the correct appliance? Reduce force to 800 gram, only nighttime wear. Direct elastics horizontal towards occlusal plane or place elastics on the inferior surface of the maxillary plane. So correct answer is option C. So I am getting many option. One second. I am getting many comments here. These are actually comments. They are not questions. They are comments. They are personal comments rather. Fine. Okay, fine. So this again we have talked about in the chapter on orthopedic appliances, right? So this is the appliance. This is the parts of the face mask. We put an elastic here, but the vector of growth of the maxilla is downward and forward, which we don't want because the LAFH is already increased. So we'll just change the direction of the elastics into being more horizontal. Okay. Next. All right. So next question. This is what I was talking about. It's a different way of presenting the same question what we discussed earlier. The video of maxillary arch expansion, appliance undergoing screw tightening. What will you see? Anterior midline diastema, anterior arch crossbite, distalization of molars, and skeletal expansion. The correct answer is anterior midline diastema. Again, you will see here in a occlusal radiograph, once you have done the activation, once the activation schedule has been completed, you will observe the presence of a midline diastema. And that is a clinical indicator that adequate amount of expansion has already taken place skeletally. Okay. Next. I have never understood better in my college after lectures. Ortho is easy for me. Thank you, Sanjana. I have seen all videos other than you No one was. Okay, got it right on the last moment. Revise it from your video's last moment revision. Thank you so much. So next is identify the appliance below. It's a simple direct question. Is it a twin block, bionator, activator, or a Frankel? So this is a twin block appliance. Nothing much to talk about here. You already know what is a twin block. It's a functional appliance having a standard design of acrylic part, wire components, and a delta clasp. Okay, and we have an inclined plane and 70-degree angulation. All of these things are written in the notes. Fine. Not even in college we got such deep understanding about the subject. Okay, fine. Okay, so there was one more question. Okay, I'm coming to that question in a while. Identify the following appliance. Again, it's a no-brainer. Quad helix, W arch, Hyrex, or transpalatal arch. Is it? What is the correct answer? It is quad helix. Again, a comprehensive description of this appliance has been given in the notes in the chapter on arch expansion. All right, you can read it from there. A mandibular second molar is drifting mesily due to premature loss of mandibular first molar. What should be done to upright the tooth with minimal intrusive effect? So we have a proper term and condition in the question. We don't want intrusion. So this is what has happened. The molar has tilted mesily due to premature exfoliation of the first molar. Now, what can be done to distalize the molar? That is what the question is asking. Full fixed appliance with continuous arch file leveling, uprighting spring using a segmental sectional arch wire, heavy continuous force with rectangular stainless steel arch wire, or extraction of adjacent first molar and spontaneous uprighting. What do you think should be the answer? The correct answer should be uprighting spring using a segmental or sectional arch wire. So this, again, we have talked about in the chapter on adult orthodontics. All right, so you can see here, this is a very common clinical situation where the third molars or the second molars are tilted mesily due to premature loss of the adjacent tooth. It is a it's a very common clinical problem. So what do we do in that? We have to upright the tooth. Either we upright the root or we upright the tooth. Any which ways, we have to use sectional arch mechanics. Sectional arch mechanics along with loops, along with certain loops like T-loops or certain uprighting springs also. So that is the correct answer. You can see here these loops are added here and the entire molar can be tilted in a proper way. Okay, so correct answer will be option B. There were open coil springs in one option. So elastic karke koi option tha. Options were different. Okay. See, again, this is a recall basically. You cannot have the exact language of the options or the question. Okay, even if there is, okay, 1 second. I'll modify the option. Full fixed appliance with continuous archwell leveling with open coil spring. Open coil spring. I'll add the open coil spring in the option A. Okay, so that is also an option, but still option B will be better than option A. Which of the following part of the appliance needs fixing repeatedly as they get loose because of repeated insertion and removal? Because of repeated insertion and removal. Again, we have talked about that in the chapter earlier in recording and live lectures. So it is the Adams clasp basically, which gets loosened due to repeated removal, repeated insertion. There's something called metal fatigue. So we have to activate this appliance again and again, or we use an alternative clasp. We use delta clasps. Sometimes, whenever, 1 second, it was WH, not quad helix. Okay, fine. So we have to take care of the metal fatigue basically. So that metal fatigue is not seen in delta clasp as frequently as it is seen in Adams clasp. Okay, so according to this, the correct answer will be option C, that is the Adams clasp. So this is what I have already talked about. So delta clasps are more fatigue resistant than Adams clasps. So that's why they are more useful in the standard design of twin block. We can even use delta clasp in normal Holly's appliance also. Okay, all were Adams. There were different joints and different options. Different options. Okay, yes, all images were Adams clasp, and they asked which part to modify if it becomes loose. Okay, fine. All right, I'll modify the question for you. It's okay. These errors do creep in. So we have the parts of the Adams. This is the arrowhead, the bridge, the crossover wire, and the retentive clasps. So this is the bridge. This is the arrowhead. Sorry. My mistake. This is the arrowhead. And this is the bridge. Then this is the crossover wire. And these are the retentive tags. Now you tell me the answer. What should be the answer? It is the crossover wire. Whichever option that was, A, B, C, or D, the correct answer is crossover wire. So this is the wire. This is the wire which we have to modify every time and again. All right. Next, a boy presented with midface hypoplasia and reclusion. A boy presented with midface hypoplasia and reclusion with breathing difficulty and maxillary posterior crossbite. Not corrected with timely adenotonsillectomy. Patient has normal BMI and normal mandibular position. Which of the following is suggested for its management? Transverse expansion of the maxilla, weight loss for opening pharyngeal airway, mandibular advancement for correction of obstructive sleep apnea, or maxillary expansion with face mask. So it should be maxillary expansion with face mask. Okay. So we have midface hypoplasia as well as we have reclusion. And we have posterior crossbite also. So the problem lies in the anteroposterior plane and in the transverse plane. So both of these problems can be corrected by maxillary expansion with a face mask. So this again we have talked about in the chapter on orthopedic appliances earlier. See, arrowhead you are asking me. Okay, arrowhead, actually it is the arrowhead which we need to which arrowhead, fine. Arrowhead is just for retention purpose, guys. We cannot simply move the arrowhead more into the undercuts of the tooth. To do that, we have to grasp the part of the appliance coming out from the acrylic plate, that is a crossover wire, and we have to bend it slightly towards the tooth. That is how the arrowheads are going to engage the undercuts properly. All right. Next question. The tooth movement was reduced. Upon evaluation, the force came out to be excessive. What is the reason? Bone deposition on opposite side, hyalinization of PDL, increased osteoclastic activity, or cementum resorption only. So the correct answer will be hyalinization of PDL. So whenever the forces of acting on the teeth come under pathological category, heavy forces, the body responds by hyalinizing the PDL. Okay, there is rearward resorption. There is resorption from the adjacent marrow spaces, and these are the characteristic features of hyalinization of PDL. And all these things, they reduce the rate of tooth movement. All right. So again, we have talked about that in the chapter on biology of orthodontic tooth movement. It's right there on your screens. Everything is written in the notes. So we are talking about undermined resorption, indirect rearward or endostal resorption, where we talk about hyalinization, and that is the area of PDL devoid of blood supply. So the body has to spend little extra effort and time to get rid of this hyalinized zone, and that is the reason why the tooth movement gets delayed during that time. Okay. The tooth, which was moving steadily earlier, suddenly started tipping. What could be the reason behind it? Now, this is a question from biomechanics. If you understand the concepts of biomechanics in orthodontic tooth movement, you will be able to answer this question properly. The center of resistance shifted to the coronal or cervical side. The center of resistance shifted to the apical side. No change in resistance or same center of resistance maintained. And change in force magnitude without change in force direction. So what should be the answer? I think the answer should be the center of resistance has been shifted to the apical side. Why? Because any force acting on a tooth which is away from the center of resistance of a tooth is going to generate a rotational tendency of the tooth, which is called as moment, right? So the change in moment, and there's one more parameter called moment to force ratio. For controlled tipping or for controlled tripping, the moment to force ratio should be how much? 6 to 8, right? 6 to 8 is to 1. Or for uncontrolled tipping, it should be 0 to 5 is to 1, right? So when the controlled tipping is changing to uncontrolled tipping, the moment to force ratio is also changing, but the force has not been changed. Only the moment has changed. So the moment can change only under one condition: when the center of resistance has shifted apically. It can happen because of loss of surrounding alveolar bone also. So this is what we have talked about in the lecture. So whenever the loss of alveolar bone is there, there will be apical moment of center resistance, and hence there will be change in the moment to force ratio. So that is the reason why a tooth which was moving steadily, let's say which was moving bodily tooth movement, it has now suddenly started tipping. So the reason could be apical movement of the center of resistance of the tooth. Question was, it was showing bodily movement earlier when it started showing tipping. Yeah, that's what I'm saying. Okay, so the correct answer is option B. Next, identify the type of face mask. So we have got different types of face mask. Is it delayed, petite, reversible headgear, or chin cup appliance? So we have talked about that in the chapter on orthopedic appliances again. There are 4 types: Hickam type, delayed type, petite type, and Turbinger type. So this is the delayed type of face mask, and this is the petite type of face mask. The question, the image is exactly of the delayed type of face mask. So the option, correct answer will be delayed face mask. Okay, simple question. Again, this is a no-brainer. Identify the marked area. We have sella turcica, carotid canal, optic canal, or sphenoid sinus. So this is the question from Cephalometrics. So we have talked about different anatomical landmarks, different soft tissue landmarks, bilateral landmarks, unilateral landmark, constructed landmark, anatomical landmarks, everything. So this is the point of interest. It is nothing but sella turcica. Simple question. So we have a list of all the landmarks marked in a radiograph in their notes in the chapter on cephalometrics. So we have the sella point right in front of you right here. That is exactly what was asked in the exam. Okay. And we have different soft tissue cephalometric landmarks also for your reference. Next, what is the correlation between periodontal treatment and orthodontic extrusion when the tooth is fractured from below the gingival margin? Now, this is a tricky question. This is a clinical application-based question also. We sometimes come across patients who have unfortunately got their tooth fractured because of any trauma or anything. They might have had a unfortunate incidence of falling down from a moving bike or anything, a bat hitting, a ball hitting. So we have situation when the tooth has been fractured at the gingival margin. Now, what to do about it? First, we have to extrude the tooth. So this is the clinical condition. This is the fracture. So we have to first, and this is the adjacent tooth, normal adjacent tooth, right? So we need to first extrude the tooth slightly. That can be done using a hook, or that can even be done using a magnet, attracting magnets. We have to extrude the tooth up to a certain limit. The more the extrusion, the lesser will be the periodontal bone support, and the entire onus will fall onto the tooth rather than on the root, right? So we can extrude it up to a certain limit only. We can extrude it till the time the crown to root ratio becomes at least 1:1 minimum. It should not be more than 1:1. It should not be more than 1:1. So correct answer will be option B, that is 1:1 crown root ratio shows least progress in the treatment. Okay. So this is again we have talked about in the chapter on adult orthodontics. You can see here right in front of you. This is a clinical situation which required extrusion, and here also you can see here that the crown to root ratio should be minimum 1:1. Minimum 1:1, 50% crown, 50% root in adult population. Okay. Okay, progress. Most prognosis. Yeah, sorry. It is prognosis. All right. Akriti Fanda, it is prognosis. Taken. All right. Next question. What is the limitation of clear aligner as compared to conventional orthodontic treatment? So clear aligner we have talked about in comprehensively in different situation, different clinical patterns, everything different image-based question, different discussions. Single tooth extrusion, mild crowding, midline diastema closure, or intrusion of the whole arch. So we have to first know what are the malocclusion which are a little difficult to treat by aligners. So crowding spacing more than 5 mm, skeletal anteroposterior discrepancies, CRCO discrepancies, severely rotated teeth by more than 20 degrees, and open bite anterior and posterior. Difficult to treat malocclusions also include extrusion, severely tipped tooth by more than 45 degrees, teeth with short clinical crowns. For that, we need to do crown lengthening, multiple missing teeth arches, and closure of bicuspid extraction spaces. So, extrusion of a tooth or of a complete segment of the arch is the major limitation of a clear aligner as compared to conventional braces treatment. So, correct answer will be single tooth extrusion. One of the option is anything more than is well okay, anything below shows poor prognosis. Yes. If the options are minimum, it was prognosis. Least progress means good prognosis. Okay, options were different. As I said earlier, guys, these are recall questions. You cannot expect this exact language of the option in the discussion. Okay. I've tried my best. Myself and the entire team at DBMCI have tried their best to collect the questions from different sources, from different students, and they have compiled everything together in this presentation, which I am presenting to you. Okay. Extrusion is difficult with liner. Yes, absolutely. Question was in moderate difficulty. Extrusion of the quadrant. Okay, moderately difficult was asked. Yes, the correct answer will be single tooth extrusion. So based on the language, our answer might change. Yeah, not exactly. I have tried my best to cover the entire things in this session, in this 45-minute session. So even if the language is slightly different, it should not make any difference in choosing the right answer. That's what I want to say. All right, guys. So this is the answer key for you. Based on my own research, based on the topics what I've taught you from different textbooks, these are the answers. This is the answer key. If you have any doubts, you know where to find me, and I'll be very happy to help you guys. Dr. Divya is sitting right in front of me. So hello, Dr. Divya. All yours. The session is all yours. Thank you so much. Good evening, guys.
So, a very good evening, everyone. I'm Dr. Divya Gupta, the original guru of Periodontics at DBMCI MDS. And today we are here to discuss the questions of NEET 2026 in Periodontics. So before we start the session, I would like to thank Dr. Kunal for introducing me. And students, first of all, tell me, how was the paper? Overall, I know the paper was little bit lengthy and it was a moderately difficult type of paper, right? But I would just like to know from you all that how was perio per se, and how were the questions? Like mostly when I went through the paper, when I went through the questions of perio, I would say, okay, yes, in perio, the questions were more concept-based questions, but the topics were mostly from the repeated topics which we have discussed in our live sessions as well as recorded sessions, right? So tell me, perio was hard. Anirban is saying perio was hard. Yes, it was a little bit difficult paper, truly speaking. And the questions mostly were concept-based questions. Mostly the questions were from chronic periodontitis, oral changes in female. All those questions were concept-based questions. But once when you apply, you read the question, at first you are a little bit startled, right? Okay, kya पूछ लिया examiner ने? But if you just mark the keywords, if you just focus on the keywords, I will tell you what were the keywords in the questions. Then it becomes a little bit easier for you to understand the question and answer those questions, right? I would say yes, the paper was moderately difficult. There were approximately 18 questions from Perio. And without wasting much time, let us start with the discussion of the paper. Paper was lengthy. Yes, students. So the first question. So this is an integrated question. Directly in perio, we have not studied this. But in medicine, definitely you might have studied it, and you can apply your knowledge of medicine here also. So let us read the question first. A patient with chronic kidney disease undergoing maintenance hemodialysis. Patient with chronic kidney disease undergoing maintenance hemodialysis requires periodontal therapy. Which of the following is the most appropriate time to perform periodontal therapy in such patients? So let me first read out the options. Option number A is on the day of dialysis. Option B is just before dialysis. Option number C is 1 day after dialysis. And option D is don't do periodontal treatment. So guys, it is not like we don't do periodontal treatment for a kidney patient. If a patient requires treatment and if the patient is undergoing hemodialysis, see, 1 day on the day of dialysis, definitely the patient has underwent dialysis, and in dialysis we use heparin, right? We use heparin. Heparin is what? Heparin is an anticoagulant, right? Anticoagulant. So if we are planning to do periodontal therapy on the day of hemodialysis, there are more chances of bleeding. So we should avoid doing it on the day of therapy. Just before dialysis means on the day before, 1 day before dialysis is also not recommended, because the patient is in a condition of shock. Why we are doing dialysis on alternate days? Why we are doing dialysis for a patient? We are doing it so that all the metabolic products, waste products which are there for the patient can be removed from the patient's body, right? Or just before dialysis, the patient has high amount of waste products, metabolic waste products in the body. This would impair the healing capability of the patient. So that's why 1 day prior also is not a good time to do periodontal therapy. But yes, 1 day after the treatment, the patient is more energetic. The heparin level is lowered into the blood. Therefore, there will be no increased chances of bleeding. Therefore, the correct answer for this question is 1 day after dialysis. Okay, understood? Any question? I hope the options were like this only. Also, as we are discussing the questions, guys, if you feel that any option was like, we have done this, we have received these questions from our students only. And if you feel that some question was different or some option was not there, you can definitely comment in the chat box. We will take that into consideration. Okay. So now the next question, a 29-year-old. So this is a repeat question, right? Directly, it is not a direct pick. It is not a direct pick, but definitely it is a PYT. It is a previous year topic question. This, I'm repeatedly saying that we get questions from the phases of treatment plan, right? So this is a question from phases of treatment plan. So a 29-year-old patient has to go on maintenance therapy after active periodontal treatment. Here they have clearly mentioned maintenance therapy. Which phase is that? Options are, this is a direct question. This is a fact which we just need to remember it. It is a small topic from perio. So option number A is phase 1. Option B is phase 2. Option number C is phase 3. Option number 4 is phase 4. Here answer is phase 4. Maintenance phase, right? Phase 4 is maintenance phase. Understood? This we have given in our notes. It is clearly mentioned what is maintenance phase, what are the different phases of periodontal treatment plus phase 1, what is phase 1, what is phase 2, phase 3, phase 4. Okay. So yes, this was from a repeated topic. Now the next question. So a 19-year-old patient is seen in a health checkup camp. The patient's age is 19 years old. This is an IBQ. The patient shows gingiva covering the third molar with pain on biting, red and swollen gums. What is the diagnosis? So definitely it is involving the third molar. The third, in the image you can see that the gingiva is covering the third molar. It is an operculum, right? It is an operculum. So the patient is having pain on biting, the gums are swollen. So here, what will be the answer? Yes, most of you might have marked it right only. This is also a direct question, right? Options are, let me just read out the options first. Option number A is NUG. Option number B is pericoronitis. Option number C is aggressive periodontitis. And option number D is periodontal abscess. Here, the answer will be option number B. It is pericoronitis. Okay. This also we have discussed in our recorded sessions. See here, clearly in our notes, in our periodontics note, it is mentioned that in pericoronitis, involving the third molar, you will have pain, swollen gums. Okay. Now, okay, Kalima is saying they asked after which phase you do maintenance therapy. Here they have in this question, beta, it is given that a 29-year-old patient has to undergo maintenance therapy after active periodontal treatment. Which phase is that? Okay. According to this question, the answer will be phase 4. Phase 4. Okay. But yes, if they have asked, the question was like, which phase you do maintenance therapy? If the question was like, after which phase you do maintenance therapy, then guys, tell me about the options also. You do maintenance recall for the patient after phase 1 also. You do it after phase 2 also. You do it after phase 3 also. You do it after every phase, guys. So just I'll check this again. So maintenance phase is done after each and every phase. After each and every, see, after phase 1, you will see here, there is maintenance phase. After phase 2, there is maintenance phase. After phase 3, there is maintenance phase. So maintenance phase is after each phase. Okay. Now the next question, the fourth question. What is the cause of this type of bone loss? So there were radiographs given. Such question was also asked for the first time in NEET MDS. Yes. And there were 4 radiographs, 4 IOPAs given. And in those IOPAs, not 4, approximately 1, 2, 3, 4. 6 IOPAs were given. And in those 6 IOPAs, you can see incisors are given. In the incisors, there is bone loss. There is bone loss. And that bone loss is that bone loss is a horizontal bone loss. That bone loss is a horizontal bone loss. It is not an angular bone loss, right? In the premolar region also, there is horizontal bone loss. In the molar region also, there is horizontal bone loss, right? So such type of bone loss occurs due to option number A, trauma from occlusion only. Option number B, plaque-induced bone loss. Option number C is NUC, and option number D is aggressive periodontitis. So the answer for this question, in aggressive periodontitis, you will see angular bone loss at least around the molar regions, right? But here you can see in the molar also there is horizontal bone loss. Trauma from occlusion, you will not see such type of bone loss. Okay, in trauma from occlusion, there will be smiled angular bone losses. That too, initially there will be crestal bone loss. So trauma from occlusion is also not the answer. NUG you cannot say unless and until you have some clinical scenario, right? And aggressive periodontitis we already discussed. So the answer to this question is option number B, which is plaque-induced bone loss, which is chronic periodontitis. Chronic periodontitis. Okay. Now the next question. So this also, chronic periodontitis, aggressive periodontitis also we have discussed in our notes. It is giving clearly all the features, the radiographic features of aggressive and chronic, all those we have discussed in our notes, guys. Okay. Now, give incisors, ma'am. Most of them were premolars and molars only. Okay, I'll just see the chat once. Ma'am, horizontal bone loss there in exam, and option chronic periodontitis. Okay, so in option, some students are saying that there was chronic periodontitis. If there was chronic periodontitis, that will be the answer. D, angular was given, angular bone loss was given. Ma'am, in exam images showed angular bone loss. This is not incisors, ma'am. Most of them were premolars and molars only. 4 radiographs were given. Okay, 4 radiographs were given. If incisors were given and if there was horizontal bone loss, it will be chronic periodontitis only. Okay, question was specifically given angular bone loss for sure. Okay, students will confirm this. Don't worry. If it was angular bone loss, remember, if it was angular bone loss, if angular bone loss seen around the radiographs, then it can be aggressive periodontitis also, but we will have to confirm this. Okay. Now the next question, which is the laser which is used in dual mode for soft tissue as well as ablation of hard tissue and bone, as it has affinity for water and hydroxyapatite? Options are diode laser, option B is carbon dioxide laser, option number C is erbium YAG laser, and option number D is ND YAG laser. So here the answer will be, guys, erbium YAG. This also in the recent live videos I have discussed clearly that erbium YAG and erbium chromium YSGZ lasers are the lasers which can be used for hard tissue as well as for soft tissue. See here, these are the lasers which can be used for soft tissue as well as hard tissue laser. This I have discussed in the live session, in the recent live session. Okay. So the answer will be erbium YAG. Now the next question. A young boy comes. So 2 questions this time were there from lasers. And I'm repeatedly saying this in my classes that yes, lasers now is like a recent trend, and since last 3 to 4 years, every year 1 question is coming from the lasers. This time there were 2 questions. Okay. So now the next question is, a young boy comes to the OPD with swelling on the lip. So this is a mucocele. What is this? This is a mucocele, right? This is a mucocele. It has been treated. Which treatment modality is used? So this is the treatment. This is before, this is after image. This is before and this is after image. So here they are asking which treatment modality is used. So guys, first, this is a little bit tricky and difficult question. First, you must know what is this. This is a mucocele. Let us see the options first. Conventional option number A is conventional scalpel excision was done. After a scalpel excision, you will definitely see bleeding. But here in the image, you can see that there is no bleeding, right? The tissue is completely fine. It is no bleeding. It is charred, but it is not burned. So definitely, it is not bleeding. So it is definitely not a conventional scalpel excision. Option B is laser. Yes, laser can be one of the answers. Option number C is cryotherapy. Cryotherapy means we are using cold. We are using cold for treating the condition, but here cryotherapy is not used for mucocele and incision and drainage. Incision and drainage is not done. It is just in mucocele we have to remove the whole of the cyst from the lips. So here we are using a laser therapy. The answer to this question is laser. Okay. Now the next question. So this, in the lasers, we have discussed that how the lasers, we have discussed thoroughly the topic of laser in our live sessions, in our recorded sessions. We have discussed lasers very nicely, and in that we have discussed the uses of laser as well. Now the next question. The image shows stippling. This is a PYT, right? This is a PYT, previous year topic. And here you can see that there is stippling. What is the cause of this stippling in the image? Options are option number A, interlocking of epithelium with connective tissue. Option number B is keratinized width. Option number C is melanin, and option number D is epithelium. So here there is interlocking. Stippling is why? Stippling is present because of the epithelium, the retipex, which are there into the connective tissue. So it is interlocking of the epithelium with the connective tissue. So the answer here is option number A. Okay, answer here is option number A. Now the next question, option number A. Question number 8. A 45-year-old male patient reported to the OPD with gingival enlargement. This is also a previous year topic. Discussed it, and I have already told you that drug-induced gingival enlargement is a very, very important topic which you must know by heart. So this is a question from gingival enlargement. The patient has history of epilepsy. Clearly, it is mentioned the patient has history of epilepsy and is on medication since 20 years. What is the diagnosis here? So it is a drug-induced gingival enlargement. It is not a leukemic enlargement. It is not an inflammatory enlargement or a hereditary gingival fibromatosis. It is A. Okay. So again, this is a PYT. Okay. Now the next question. See, in our notes, it is clearly mentioned that phenytoin is one of the drugs which is responsible for causing gingival enlargement. Similar type of question was asked, I think 3 to 4 years back also. So this is a question from a question bank. Now the next question. Guys, this was a video question and it was a little bit tricky question for some of you, right? Some of you said that the video was not clear. So I will be showing you the video here. And this same image, the video which they have used, the same image I have shown you in our live sessions as well. Okay. So the video showed the tunneling technique of GTR. What is the significance of this technique? Options are increase in the thickness of connective tissue, decrease in the thickness of connective tissue. Option number C is stippling of gingiva. Option number D is increase in marginal tissue thickness. Let me show you the video first. So this was the video which was there. This was the video which was there. Here they were inserting the membrane after raising a tunnel, after raising a partial thickness flap. So guys, basically this technique, the tunneling technique is used for recession coverage. Okay, the tunneling technique is used for recession coverage. The main purpose of using a tunneling technique too is to increase the width of keratinized gingiva. Increase the width of keratinized gingiva. Keratinized gingiva. But here in the question, in the options, if the width of keratinized gingiva was not given, then the best answer to choose is increase in the thickness of connective tissue. So, ma'am, I put increasing color of gingiva. So guys, it is not bringing about any change in the color of the gingiva, right? It is not. If in the options there was increase in the width of keratinized gingiva, that will be the answer. But if increase in the width of keratinized gingiva is not there, then the best option to choose amongst these options is increase in the thickness of connective tissue. Understood? If it was change in the option was color of gingiva, if the option was color of gingiva can be changed, that is not the correct answer, guys. Just understand the correct answer is increase in the thickness of connective tissue or increase in the width of keratinized gingiva. Okay. Any membrane, if they are using connective tissue graft, if they are using GTR, if they are using transparent GTR, anything they are using, guys, it will be for increasing the width of keratinized gingiva or increasing the thickness of connective tissue. Someone is saying improving the contour of the gingiva was given. If in the options improving the contour of gingiva was given along with increase in the thickness of connective tissue, still A is better option to choose. Okay. Stippling of gingiva will not happen because of, okay, Manu is asking why not stippling. Stippling will not happen here. After we are putting a GTR membrane, it will not increase, there will be no stippling present in the tissue. It will be bringing about change in the attached gingiva, width of attached gingiva basically. As width of attached gingiva is not mentioned in the option, best option to choose is increase in the thickness of gingiva, okay? Now the next question. Marginal gingiva thickness will not change because of this. What is marginal gingiva? Marginal gingiva is the gingiva which is surrounding the neck of the tooth, right? That is the marginal gingiva. In recession cases, the marginal tunneling technique, guys, we are using for recession. You have to be clear with the concepts. And I have taught this technique. See here, this is pouch and tunnel technique. Here, tunneling technique is used for what? See here, tunneling technique is used for this area, for recession coverage. So by doing a tunneling technique, what we are doing? We are increasing the width of attached gingiva. But as it is not given in the option, see the same image they have given here. I have taught you this in the class, right? The same image they have given, the same video they have given in the question also. Chalo. Now the next question. What is it called when only isolated part of bone is denudated? Isolated part of bone is denuded and adjacent part is covered with alveolar bone. Adjacent part is covered with alveolar bone and gingiva. When there are isolated parts of the bone which are denuded and it is covered with gingiva, then it will be, let me tell you the options first. Option number A is fenestration. Option B is dehiscence. Option number C is ledging. Option number D is exostosis. This is also a PYT. And here the answer will be fenestration, A. I hope most of you marked it correctly. Okay. Now the next question. A 26-year-old pregnant woman in her second trimester reports to the dental OPD with. So such type of questions are case-based questions and they have given, like, the question is very big, right? When we read such questions on a computer screen, sometimes we lose our focus. We are not able to mark the keywords. We are not able to identify the keywords. So yes, in that sense, the paper was a little bit lengthy because while reading only, you know, we become confused by seeing such questions. So such questions were asked, many such questions were asked basically in this time in NEET MDS. So let me read the question first. A 26-year-old pregnant woman in her second trimester reports to the dental OPD with bleeding gums and mild mobility of teeth. On examination, only scanty plaque deposits are present, but radiographs reveal generalized horizontal bone loss. She has no history of systemic illness and maintains fair oral hygiene. What is the most likely reason for the periodontal changes in this patient? Options are option number A, hormones only. Option number B, plaque, progesterone and estrogen. Option number C, plaque only. And option number D is reduced host response during pregnancy. Now guys, a little bit tricky question this is, but we have discussed that solely hormones, solely increase in hormones will not cause pregnancy gingivitis or pregnancy periodontitis. For these hormones to exaggerate the response of gingiva, plaque should be present. So plaque plus female sex hormones are together responsible for causing periodontitis or bringing about gingival changes in females. So the answer to this question is option number B. The second best option to choose here was reduced host response during pregnancy. Okay, but B is always greater than D. Remember this. Okay, now the next question. During planning of periodontal flap surgery, certain principles regarding incision design and flap reflection must be followed. Yes, this is also a little bit tricky question, a tough question, I would say. This was a little bit tough question, but let us just read and try to find how we will answer such questions in future. Okay, so during planning of periodontal flap surgery, certain principles regarding incision design and flap reflection must be followed to ensure adequate access. Preservation to ensure adequate access, preservation of blood supply, proper healing at the surgical site. Which of the following is not? So mark the word here. Which of the following is not considered a correct principle of periodontal flap surgery? Now, we have discussed when vertical incision should be given, when horizontal incisions should be given in our periodontal flap surgery chapter, right? Now, here the options are, option number A is vertical incision should be obtuse to the horizontal incision. Yes, this is true that vertical incision, I have already told you that the vertical incision in the notes, in the live sessions, that these vertical incisions should not be at an acute angle, they should be at an obtuse angle to the horizontal incision, and they should have a broad base so that there will be adequate blood supply and the healing will be faster, right? So vertical incision should be obtuse to the horizontal incision. This is absolutely correct. Next is, in mandible, vestibular incision is given for periapical lesions. If we are treating a periapical lesion, we cannot take the flap from the sulcus. We have to give a periapical incision. We have to give an incision into the vestibule to reach the apex of the tooth. So this is also correct. Next is, vertical incision is given for better view. One of the advantage of giving a vertical incision is that more flap reflection can be obtained, and thus the visibility of the underlying structures increases. The fourth option is horizontal incision given at sulcus for gingival enlargement. Now this is not correct, guys. In gingival enlargement, just by giving a sulcular incision, horizontal incision inside the sulcus is what? It is a sulcular incision, right? It is a sulcular incision, and by just giving a sulcular incision in the sulcus, we will not be able to remove the enlarged gingiva. For removing the enlarged gingiva, we need to give internal bevel incision or external bevel incision. These two incisions should be given to remove the enlarged gingiva. So the answer in this question is option number D. Okay. Saloni is saying, ma'am, option was horizontal incision in gingival sulcus in periodontally compromised tooth. Horizontal incision in gingival sulcus. If that was the option, I would have to see, then that is also correct, because in periodontally compromised teeth, we give horizontal incision, right? Clavicular incision at sulcus done, right, ma'am. No, third option was interdental preservation for better. Okay, guys, we'll check this. We will make a note of this and see. But if these were the options given, the answer will be D. Okay. Now the next question. Question number 13. The soft tissue attachment around dental implants. The soft tissue attachment around dental implants differs histologically from that around the natural teeth and plays an important role in maintaining the peri-implant seal. This is also a PYT. already discussed in the recent live class only. I said clearly that now they are focusing around more about the soft tissue around the implants. So you must know questions from soft tissue around the implants as well. Which of the following best describes the attachment of connective tissue fibers to the surface of dental implant? Options are option number A, direct attachment of Sharpey's fibers. No, there is no direct attachment of Sharpey's fibers. It is there in the natural tooth. Attached via hemidesmosomes. They are attached via hemidesmosomes plus basal lamina. So here that is missing. Option number C is perpendicular attachment to the implant surface. It is not perpendicular attachment. It is the collagen fibers run parallel to the implant surface. So the answer here is option number D. It will be option number D. Attached just via hemidesmosomes is not correct. It should be hemidesmosomes. Hemidesmosomes plus basal lamina. This, since last 3 years, they were asking this question in INI. Since last 3 years, okay? But here basal lamina is not given in the option. So the better answer to choose here is option number D. Okay? Now the next question. This also see, we have clearly discussed in our live classes and our recorded sessions. Now, regeneration of periodontal ligament. Regeneration of periodontal ligament following periodontal therapy depends on the activity of specific cells capable of forming new collagen fibers and restoring attachment apparatus around the tooth. So, see, they can ask directly which tissue, which cells are responsible for periodontal regeneration, right? This question, the basic, what they want to ask in this question is this: which cell is responsible for regeneration of periodontal ligament? But after reading such long question, I can also lose my focus, right? Such type of questions made this time's paper a little bit difficult to apply our concepts also. So, which of the following cells is primarily responsible for regeneration of periodontal ligament? So, this much part of the question was sufficient. All of this part is unnecessary, right? So, the answer to this question is option number B, which is fibroblast. Okay. Now, the next question. A smoker with chronic periodontitis shows minimal bleeding on probing. A smoker with chronic periodontitis shows minimal bleeding on probing during periodontal examination. What is the most likely reason? So, the question is asking, in a smoker with chronic periodontitis, there is less bleeding. So, what is the reason for that? Options are vasoconstriction because of nicotine. Option number B is fibroblast suppression. Option number C is increased neutrophil function. And option number D is enhanced immune response. The answer to this question is vasoconstriction because of nicotine. The answer is, as there is vasoconstriction, definitely there will be decreased GCF and there will be the patient will have decreased bleeding on probing. Okay. Now the next question. A middle-aged woman reports to the dental OPD with pain and localized swelling. With pain and localized swelling in the gingiva after a fish bone got lodged between her teeth while eating. On examination, there is localized gingival redness and swelling. There is localized gingival redness and swelling, but no periodontal pocket or radiographic evidence of bone loss present. What is the most likely diagnosis? This is also a PYT and this is, I would say, a rather easier question to answer. Option A is gingival redness. Option B is gingival abscess. Option number C is periodontal abscess. It cannot be periodontal abscess. Why? Because there is no pocket and there is no bone loss. It cannot be periapical abscess as well. So the answer here will be option number B, gingival abscess. Am I not audible, guys? पीयूष भाई सुनाई दे रहा है? Okay. Guys, yes, I'm audible, and please check to the students who are not able to hear me, please check your connections. Now the next question. This also is given in our notes in the chapter of abscesses, guys. Okay. Now the next question. Furcation area has bone loss. Which structure of tooth is exposed? Furcation area has bone loss. Which structure of tooth is exposed? Options are option number A, dentine. Option number B is pulp. Option number C is cementum. And option number D is enamel. Here, they have clearly marked the arrow that after, because of bone loss, when this part is exposed, what will be visible? What will be there? It will be cementum, right? So the answer to this question is option number C, which is cementum. Now the next and the last question, which was there. The question is, which amongst the following acts as a natural scaffold? Which amongst the following acts as a natural scaffold? Here the keyword is natural scaffold as a membrane, right? So options are option number A, PGA. PGA is polyglycolic acid. Polyglycolic acid. Option number B is polylactic acid. Option number C is hyaluronidase, and option number D is polyglycolic polylactic acid. So the answer to this question is option number C. But here, if hyaluronidase is what? It is an enzyme, right? It is an enzyme. But all these three options which are there, these are synthetic scaffolds. These are not natural scaffolds. So better if this was by mistake, might be they have given hyaluronidase, but if in the options hyaluronic acid would have been there, this was a better answer to mark. But still, amongst these options, C, hyaluronidase is a better answer to mark. Okay, guys? Understood? So with this, we have completed the discussion of all the 18 questions of periodontics. If you feel that I have noted all the, all the suggestions which I got from you in the chat box, I would definitely consider them while making the, paper and make it more trustworthy for you all. So guys, thank you so much and all the best. Just remember that you did your best. You gave your best the entire year, the entire 2 years. And now just leave everything on God. He will do the best for you. Okay. So thank you so much and all the best. Now the session, next session will be taken by Dr. Priyanka for OMR. Thank you.
Hi, good evening, all of you. Good evening, all of you. And am I audible and visible so that we can start with the session? Hello, hello, hello. Okay. So, guys, welcome to NEET MDS Recall 2026 of OMR subject. And just a quick note before we begin with the OMR session that this is a recall based discussion. Okay. So, the questions that we'll be going through have been collected from you guys. Okay. The students who have already appeared in the exam, and we have tried to compile it accurately as possible. Okay. So they may not be 100% exact wording or options. Okay, so our main focus will be understanding the concepts. Okay, so that you get a basic idea about the answer, and it will be also helpful for the students who will be giving exam next year. Okay, yes, I will go fast. Okay, let us start with the first question. A patient presented with the pain in preauricular region and progressive decrease in the mouth opening. There is a history of parafunctional habit radiograph of joint. Okay, there is a radiograph which shows subchondral radiolucencies. Subchondral radiolucencies in the condylar head, irregular margins of condyle and sclerosis around it. Okay, so all the features that they have given in this question point towards which type of disease? It point towards degenerative disease. Correct? So there is a preauricular pain, there is a decrease in mouth opening, parafunctional habit. So parafunctional habit like bruxism, and the clenching. Okay. Now this parafunctional habit causes mechanical stress. Okay, mechanical stress, and due to which we have this degenerative changes that you see in the joint or condylar region. Okay, so according to the given features, okay, the most appropriate answer, and we have it in the notes also. We have it in the notes also. The features of TMJ osteoarthritis. TMJ osteoarthritis. Okay, it is a degenerative disease. Then we also have the radiographic features like flattening, then the Ellis cyst, which is a radiolucent uh, lesion on the condyle. Okay, then osteophyte, which is a extra bony projection, and if this osteophyte gets loosened and it will stay in the capsular region, it is called as joint mice appearance. Okay, so all these changes are degenerative changes, and the most appropriate answer here is Ellis cyst in progressive osteoarthritis. Yes, last option was TMJ ankylosis. Okay, TMJ ankylosis, even if there is a TMJ ankylosis, there is subcondylar radiolucency seen. Okay, subcondylar radiolucency like this. Okay, irregular margins of condyle, that is called as erosion. Okay, all these changes are degenerative changes, and all these point towards the osteoarthritis. Okay, so B option is the correct option. Okay, all right. Moving on to the second question. A woman comes to OPD saying she does not like her appearance. She is born with hemifacial microsomia. Hemifacial microsomia with deformed ear. Okay, with deformed ear and ear appendages. Radiograph showing hemimandibular hypoplasia. Hemimandibular hypoplasia, which is given in the OPG. Right side is hypoplastic as compared to left side. What is the diagnosis? Okay, so this is basically related to the syndrome. Okay, options, we have 4 syndromes given. Okay, we have to choose the best syndrome that includes all these features. Okay, easy, very easy. Hemifacial microsomia. What do you mean by hemifacial microsomia? Where one side is affected, and one side remains underdeveloped. And they have also mentioned the deformed ear. Okay, and ear appendages. So ear anomalies also there. First, facial asymmetry is there. Second, ear anomalies are there. Okay, and third one is mandibular hypoplasia. Mandibular hypoplasia. Okay, all these features point towards which syndrome? Gold-Ehlers syndromes. Okay, if we compare the other syndromes, Peutz-Jeghers may you have pigmentation and GI polyps. There is no mention of this, so this gets ruled out. Correct. Mulkerson-Rosenthal, you have fissured tongue, facial palsy, orofacial swelling, not mentioned. So this is also ruled out. Okay. And the fourth one is Sturge-Weber. So Sturge-Weber, what do we have? Port wine stain and leptomeningeal angiomas. So it is not there. So the remaining option is option number A. Very easy syndrome-based question, frequently asked. Okay. All right. Moving on to the third question. Okay. Okay, let me see the comment section. Osteophyte was in the option. Okay. You're talking about first question, right? So if there was an osteophyte, they would have mentioned about the bony projection. There would have been mentioned about antero-posterior bony projection on the condylar head. Okay. So it is not mentioned. Osteophyte is also ruled out in the first question. All right, guys. Okay, chalo. A 60 years old lady had systemic sclerosis with resorption of ramus of mandible on the posterior aspect as seen in the image. What is this sign? Okay, now systemic sclerosis. We all know what is systemic sclerosis. It is scleroderma, which is a connective tissue disorder. Okay, what exactly happens is connective tissue disorder. There will be excessive collagen deposition. There will be excessive collagen deposition. Excessive collagen deposition. Correct? Now, due to excessive collagen deposition, what happens? What are the consequences of this? We have vascular damage, then due to which we have ischemia, and then this leads to fibrosis. Okay, now due to fibrosis, what happens is it puts like the muscle groups or the skin or the cartilages, this puts excessive pressure on the bone region. Okay, so therefore what happens is there will be resorption of bone as seen here. Okay, in this case there is a resorption of posterior aspect of the ramus. Okay, so excessive pressure on bone that leads to resorption. Now here, excessive pressure on the bone, okay, that leads to resorption of the posterior aspect of mandible or ramus of mandible. Okay, now the easy thing that they have asked, what is this sign called as? Okay, now if I show you the next image, okay, can you see it here clearly? Due to resorption in this region, due to resorption in posterior ramal region, what had happened is it had got a shape like a tail of a whale. Okay, therefore they are directly asking this question that this resorption causes the change in the shape of the ramus or the condylar region, that is called as shape of tail of a whale appearance. Okay, so this is the idea behind it. Very easy, just out of box. I think 2 or 3 questions are out of box, rest questions are easy. Okay, all right. Now, next question is, yeah, this is also very easy. This image shown below, first of all, you need to identify which view is this, which extraoral view is this. Now, this image shown below shows an imaging technique which is superior to SMV. SMV is submento vertex view. Due to reduced soft tissue contrast and better visualization of zygomatic arch. Name the view. So easy, they have just asked you to identify the view and the reason of its superiority to SMV view. Okay, now we have already studied in our notes that the modified version of the SMV, modified version of SMV is jug handle view. Correct? So in the given options, what do we have? Option A, B, C contains jug handle view. Okay, so we have to choose the best option over here. Now, when you take a jug handle view, okay, you are just going to decrease the exposure. You're just going to decrease the exposure and take the view. Okay, SMV view mein whatever exposure time or voltage or current you set, you are going to decrease the exposure to take the jug handle view, so that there is an increased contrast and you can see this zygomatic arches very clearly. Okay, so what we are going to do is jug handle view is taken with the less exposure than the SMV view. Okay, so why do we decrease the exposure? Because the zygomatic arches are thin. Okay, this is a thin bone. So to avoid over penetration of the photons, we are going to decrease the exposure so that we get increased contrast. Okay, due to over penetration, what will happen? Photons will pass through this bone and the bone will appear more radio opaque. That will cause the overlapping, you can say, appearance of the arches. Okay, so we are going to decrease the exposure and take the view. All right. Okay. All right. Okay. All right. Chalo, moving on to the fifth question. Okay, it was high contrast, then you can go for high contrast. All right. Okay. What is the condition depicted in the image? So this is basically a xylographic appearance, and we have studied about the xylographic appearances, and this appearance that they have given is very easy: cherry blossom, branchless fruit laden, or snowstorm appearance that we see it in the Jogren syndrome. Very easy. Jogren syndrome. Correct? Yes. Moving on to the question number 6th. This is also very easy, direct question, direct statement in our notes. Electrical charge is transferred in bucket brigade fashion in which sensor? So this question is from digital radiography, and we have studied three sensors: CCD, CMOS, and PSP, correct? PSP plates. In which sensor the electrical charges are transferred in bucket brigade pattern? Okay, we know this answer, direct answer, under CCD. Under CCD. Okay, so in CCD sensor, charged couple device, the images are read out in bucket brigade pattern. Bucket brigade pattern. Okay, so here the answer is CCD. Answer is CCD. Just a second. Okay, so bucket brigade pattern, let's consider how these charges are transferred. So just imagine passing buckets of water people passing buckets of water in one line. Okay, from first person to second person, then third person, then fourth person. In the same way, the charges in digital sensors, what happens when we pass x-rays through tooth structure? Okay, it the x-rays pass through the structure, falls on the sensor. Correct. Now what happens is, these charges, let's say this charge pass from one pixel to next pixel, then third pixel, like this. Okay, and finally it comes to the read out register. Okay, that is a final device, or that is a final, you can say, step where the charges pass from one pixel to next, and then come towards the read out register. Here, this digital signal, these charges are converted into the image. Okay, so this is the pattern that is there in CCD sensors. The CCD sensors use this bucket brigade pattern. Okay, so this is the whole idea behind it. Okay, but direct question tha, so very easy. Now, yeah. Moving on to question number 7. This is also very easy. CBCT artifact. We have discussed this in revision lectures also. Okay. Defect shown in the image below is caused due to. So this is, can you see the faint gray circular artifact? This is faint gray circular artifact that they have asked. This is due to, or this is which artifact? This is a CBCT artifact. Okay. And this also we have discussed in our notes, that this circular artifact is due to faulty sensor. Faulty sensor. Okay. Faulty sensor leads to the circular ring artifact. This is very easy, direct question. This is the snap from the notes. Okay. So answer here is B, ring defect or ring artifact, to be more precise. Okay. All right. Moving on to the next question, 8th question. Very easy. Anatomical landmark that you see in the occlusal radiograph. Occlusal radiograph. Okay, occlusal radiograph. So here we have well-defined radiolucencies present bilaterally. These are nothing but nasolacrimal canals. Nasolacrimal canals. Nasolacrimal canals are inferior continuation of lacrimal sac that you see in the occlusal radiograph, maxillary occlusal radiograph. Okay. Yes. Yeah. About CBCT artifacts, yeah, many artifacts were given, but they have pointed arrow towards ring artifact. So you had to identify which artifact is that. Okay, there were many artifacts given. Yes, somebody, some student told me that. Okay, but they had specifically asked about the ring artifact. Okay, all right. Okay, 9th question. Patient presented with pain radiating from throat to ear. On examination, pain started from oropharynx radiating to ear. No specific trigger zone was found. What is the diagnosis? This is very easy. Neuralgia based question. Okay. Trigeminal neuralgia will ruled out because there is no specific trigger zone. Trigeminal neuralgia may you have trigger zones, and they have mentioned pain radiating from throat to ear. Okay, trigeminal neuralgia may mainly you have this around ella of nose, around corner of mouth, cheek region. All these areas are affected. Okay, so this is ruled out. Correct. Option number B, yes, it could be best option for this because the throat to ear radiating pain, okay, is there. Bell's palsy, there is no mention of unilateral drooping of the corner of mouth, absence of wrinkles, or inability to close the eye. Okay, there is no such feature mentioned to Bell's palsy, ruled out. Sphenopalatine neuralgia, this is also ruled out. This is what? Cluster headache. Cluster headache. Mainly pain is around the eye. Okay. And this is also called as alarm clock headache. So patient gets this attack at the same time of the day. Okay. If today 4 o'clock, tomorrow he'll get it at 4 o'clock. So that is why alarm clock headache. No such feature mentioned. We'll go with option number B. That is glossopharyngeal neuralgia. Okay. All right. Moving on to the, okay, this is also from notes. 10th question, patient presented with a recurrent gnathic cystic lesions, frontal bossing, calcification of falx cerebri, bifid ribs as seen in the image. All these will be additional features seen in the syndrome except. Okay, now they have mentioned about the features. Okay, they have given 4 features. You have to identify which syndrome they are talking about. So cystic lesions, frontal bossing, calcification of falx cerebri, bifid ribs. All these features point towards Gorlin-Goltz syndrome. Correct? Okay. Gorlin-Goltz syndrome. Now, in the given options, they had asked which will be the exception, which finding is not present in Gorlin-Goltz syndrome. Okay, so first, vestibular schwannoma, multiple basal carcinoma, medulloblastoma, and option number D is not recall. If anybody can recall, please put it in the chat box. Okay, but here we have our answer, so we'll go with that. So, in the major criteria or major important feature that you see in Gorlin-Goltz is multiple BCCs, basal cell carcinomas, multiple OKCs, Palmer or plantar pitting, okay, calcification of Fox cerebri, and bifid ribs. Okay, bifid ribs. These all are major criteria. So, main features are seen, these are the main features that you see in Gorlin-Goltz. Now, the next minor criteria or minor features that you see in this Gorlin-Goltz syndrome. Yes, we have multiple basal cell carcinoma. We have medulloblastoma also. Medulloblastoma is highly malignant bone tumor, especially common in children. Okay. Next is increased circumference of head. This is also feature that you see in Gorlin-Goltz, circumference of head. Next, congenital features such as frontal bossing, coarse facies, cleft lip and palate, okay, hypertelorism. These all are also seen. Next, skeletal abnormalities. Next, ovarian cardiac fibromas. These are some minor features that you see in Gorlin-Goltz. Okay, so in the given option, the exception that we have is this vestibular schwannoma. Vestibular schwannoma is feature that you see neurofibromatosis type 2. Neurofibromatosis type 2. It is related to ear. So we have hearing loss, we have tinnitus, which is ringing in ear, and vertigo. Okay, so vestibular schwannoma is the exception that you have it in Gorlin-Goltz syndrome. Okay, all right. Moving on to the next question. Easy denture wearer patient present with painful cracks and erythema at corners of mouth. Angular cheilitis was mentioned. Okay, which is the most appropriate drug? So they are just asking treatment for angular cheilitis. We have studied angular cheilitis under the classification. This is from notes. Classification of candidiasis, where we have chronic atrophic candidiasis. We have angular cheilitis. Okay, angular cheilitis. Now, if this is classification of candidiasis, then what will be the treatment plan for candidiasis? Triamcinolone. If you look at first option, this is the steroid. We cannot use it for candida infection. Option number C is mupirocin, which is antibacterial. We cannot give it for the fungal infection, correct? Metronidazole, anaerobic infection. We give it for anaerobic infection? No. So our option is option number B, which is clotrimazole. Clotrimazole, we give it as a candid mouth paint, which is a topical antifungal agent. Topical antifungal agent. Okay, patient just have to apply it over the corner of mouth. Okay. Okay. All right. Okay, some people saying exception was there. Some people, okay. It's okay, guys. We will consider exception because most of the students said there was exception word present. Okay, so we will go with the answer that we have discussed now. Okay. Okay. Last question. Okay, this is basically oral surgery question. Okay, but we will put it as a miscellaneous one. Okay, a 17 years boy, 17-year boy, examined during health camp where all the third molars were found to be erupting, and they have mentioned pericoronitis is seen with the lower third molar with extraoral discharging sinus in the region of first molar. First molar. Okay, the first molar was vital and asymptomatic. This is now what is mentioned here. Pericoronitis is present. Pericoronitis is present. Okay, and extraoral sinus was present in the region of first molar. Okay, but first molar is completely vital and asymptomatic. Asymptomatic. Okay, completely vital, asymptomatic. That means the source of infection is not the first molar. Just take a note of this. The source of infection is not a first molar because it is vital and asymptomatic. They have mentioned that. Okay, so in the given options, what do we have is Gary's osteomyelitis, migratory abscess due to subacute pericoronitis, submandibular space infection due to pericoronitis, and condensing osteitis. The most appropriate answer for this is migratory abscess due to subacute pericoronitis. Okay, due to subacute pericoronitis. So the abscess which is due to pericoronitis, whatever infection that is there is spread, okay, that has spread at the distant site. Which site? In the first molar region. In the first molar region. Okay, so that is called as migratory abscess due to the presence of subacute pericoronitis. So option B is the correct answer. Option B is the correct answer here. Okay, so this here we complete our questions from OMR subject. Rest of the question that are also there in oral medicine will be covered with oral pathology because there was a histopathological features included in that. Okay, so yeah. Okay. Yeah. All right. So clobetasol was mentioned in the previous question, but the uh, basic or drug of choice that we use for the candidiasis, okay, oral candidiasis, the first choice, first preference is always clotrimazole. Okay, first preference is always clotrimazole, so we can go for clotrimazole here. Okay, all right. We have completed our questions from the OMR subject. I hope you guys have marked the correct answer, and let's hope for the best, and all the best to all of you. Now this
Hello, everyone. Welcome to Physiology Question Discussion with me, Dr. Abhirami, the Physiology faculty. The questions were around 6 questions in Physiology, and all of them were direct questions from Physiology. And I'm so happy that all of the questions are just repeat questions from whatever we have discussed in our sessions. Nothing more than that. Nothing from out of bounds. It's all direct questions, very easy questions from Physiology. And most of the questions directly also we have discussed the same question. So let's start off with the first question. So one question which I found that we were not able to get the correct options, I think, because homeostasis is maintained by, homeostasis means this is maintenance of constancy of the internal environment of the body. So constancy of internal environment of the body, for example, body fluid maintenance, how your body water content is maintained, different ions, how they are maintained, acid-base balance, which is related to buffer system, and neurotransmitters, they play a role in signaling, all signaling of the body. Nervous system, endocrine system, your hormonal mechanisms, they are also a part of feedback control mechanisms. So I'm not sure about the other. I think one of the option has been changed, or we were not able to recollect the one of the correct options. So according to this question, homeostasis is maintained by, these options are there, all of the above. All of them help in homeostatic mechanisms. So either it should be all of the above, or one of the option has been changed, because if you understand what is homeostasis, maintenance of internal environment of the body, all of them are ultimately going to help you in maintenance of internal environment of the body. The second question was, after 24 hours of fasting, yes, the clue here is fasting, an individual develops periodic gastrointestinal contractions. So it's a kind of GIT movement which is happening during the fasting state. That is the clue here. That helps clear residual food particles. So this is the final mopping up of the entire GIT, the same word we have used in our classes. The final residual food particles are cleared by this movement. Which of the following type of contraction is responsible for this activity? Yes, what is the answer? MMC, migratory motor complex. So I can show you the screenshot from our class and notes. Exactly the same image we had discussed and exactly the same terms that we had used. Migratory motor complex mediated by motilin. It happens during fasting period, just to go and check if there is any undigested food particles left over. Residual food particles are cleaned by MMC, migratory motor complex. And it happens in 3 phases. Phase 1, a quiet period. Phase 2, irregular activity. And phase 3, a burst of regular activity. So the right answer is MMC, migratory motor complex. So this is a screenshot from our DBMCI app notes. So I'm so happy that this has been asked in the exam, and I'm sure all students who have attended the class would have answered all the questions easily. So the answer is migratory motor complex. Question number 3. A lady came to OPD with weight gain. So the clue here is weight gain, tiredness, fatigue, feeling very cold, not able to tolerate cold. So they're talking about cold intolerance here, irregular menstrual cycles, and low concentration at work. Skin becomes very dry, puffiness of eyes. What are the thyroid levels? So what are we talking about here? Weight gain, cold intolerance, irregular menstrual periods, all this is related to hypothyroidism. So the diagnosis here is hypothyroidism. And in hypothyroidism, what is hypothyroidism? If your T3, T4 levels are low, that's called hypothyroidism. Whenever your thyroid hormone levels are low, as a negative feedback, TSH, thyroid stimulating hormones, would increase. So T3, T4 levels are low, whereas thyroid stimulating hormone levels are high. So that is classically the option A, where there is high TSH and low levels of T4. This also, I can show you the screenshot from our notes where we have discussed. You remember the word that we had used to easily remember the functions of thyroid hormones? I told you rates. Just to remember this word, rate. Thyroid hormone increases all the rates in your body. That is why when it increases, the rate of heart rate, that's why hyperthyroid patients have tachycardia and hypothyroid patients have bradycardia, and it increases the rate of BMR, basal metabolic rate. When all metabolisms are happening, more the metabolism, more the breakdown of materials, heat is released. That is why hyperthyroid patients become heat intolerant and hypothyroid patients become cold intolerant. And that was the clue that was given in the question. And also thyroid hormone increases the rate of lipolysis. More fats are broken down. More the fats are broken down, hyperthyroid patients become thin, and hypothyroid patients have obesity, weight gain. So these are all the hints that were given in the question. And we have already discussed the actions of thyroid hormones. So that is pertaining to hypothyroidism here. And the correct answer would be low levels of T3, T4 and high levels of TSH. Question number 4. A patient was on a dental chair for 40 minutes in supine position. So he's lying down in supine position on 40 minutes. After that, the doctor asked him to get up and he felt lightheadedness and dizziness. First of all, why is he having this lightheadedness and dizziness on standing up? The patient was lying down. Suddenly he is getting up. So all blood is pulled to your lower limbs. When all the blood goes into the lower limb, cardiac output decreases, blood pressure decreases. This is called orthostatic hypotension. On changing position, there's a fall in the levels of BP. But your body will match for this. Which is that compensatory response which will regulate your blood pressure? Yes, it is our baroreceptor reflex. Because of baroreceptor reflex, his blood pressure dropped. After his blood pressure has dropped, after some time, because of baroreceptor reflex, the patient becomes completely normal. This is a short-term regulatory mechanism. So we have discussed this also in our class, the baroreceptor reflex. This is one of the short-term regulatory mechanisms for blood pressure. Do you remember short-term regulation of blood pressure? Number 1 was baroreceptor reflex. Number 2, chemoreceptor reflex. And number 3, CNS ischemic response. All these are short-term regulatory mechanisms. Short-term means you just get up and your BP is falling. Immediately you have to correct this. So that's a short-term regulatory mechanism by baroreceptor. What is this baroreceptor reflex? Whenever there is a change in the blood pressure, for example, if there is any increase in blood pressure, this will be sensed by the baroreceptors. Baroreceptors are located on the aortic arch and on the carotid sinus. From the aortic arch, vagus nerve is stimulated, and from the carotid sinus, glossopharyngeal nerve is stimulated. They go into the brain. In the brain, the center for regulation of blood pressure is in the nucleus tractus solitarius of the medulla, and this has 2 functions. It will activate the parasympathetic vagal nucleus and it inhibits the sympathetic nucleus. Sympathetic nucleus is called as the vasomotor nucleus. And what is the net result if sympathetic is inhibited? Therefore, there is a fall in BP. So this is a short-term regulatory mechanism. Whenever there is an increase in BP, baroreceptor reflex will decrease the BP. And whenever there is a decrease in BP also, in the reverse direction, it can increase your blood pressure. So that's about the baroreceptor reflex. And this is very active within the range of change in blood pressure, 60 to 180 millimeter of mercury. Baroreceptors are very active. So this is clearly about blood pressure regulation, and the answer would be baroreceptor reflex. The first immediate response to fall in BP, short-term regulatory mechanism would be baroreceptors and the baroreceptor reflex. Question number 5. During impression taking, the patient had gag reflex. What is gag reflex? You touch the posterior most part of your mouth. The patient will have a vomiting sensation. Especially as a dentist, you will encounter this for every patient. When you ask the patient to open the mouth and put anything into the mouth, that can stimulate the gag reflex, a kind of vomiting reflex, followed by involuntary swallowing. So automatically the patient has that vomiting sensation followed by swallowing. This is a normal response. Which part of the brain facilitates this airway defense mechanism? So what are we talking about here? Clearly, it illustrates the swallowing reflex. The center for swallowing reflex or deglutition reflex is in the medulla oblongata and the pons. So this also we have clearly discussed in our class and notes that deglutition reflex The stimulus for deglutition reflexes, bolus of food. When you have food, not necessarily food, when it goes for a gag reflex, you put any instrument into the mouth that is stimulating your gag reflex. The afferents are vagus, glossopharyngeal, and trigeminal nerve, and the swallowing center is located in the medulla. From there, efferent nerves come out. Efferent nerves are trigeminal, facial, and hypoglossal nerve, and there is a reflex contraction of the muscles of your mouth, lips, and tongue, and that helps you in swallowing. So the question is about swallowing reflex, and this is almost a direct question from our notes. I'm so happy for that. So the answer would be medulla oblongata and pons. What about the other options? Cerebellum has a role in motor control. Cortex, cerebral cortex has several lobes and there are several functions. Basal ganglia helps in movements. Cortex, frontal lobe has a role in motor. Your parietal lobe has a role in sensory functions. Temporal lobe, hearing, auditory function, and your occipital lobe, vision. So this has nothing to do with swallowing reflex. So the obvious answer would be medulla oblongata and the pons. Question number 6. A 50-year-old female patient presents with lightheadedness, loss of vision, and menstrual irregularities. She is diagnosed with a pituitary tumor. So you understand that the pituitary gland is very closely located near the optic chiasm. And do you remember this diagram where we discussed in our class about the different types of lesions that happens in the visual pathway? Yes, what is happening in the optic chiasm? At the optic chiasm, both the eyes, medial fibers are crossing. The optic nerve has medial fibers and lateral fibers. From both the eye, medial fibers cross at the optic chiasm, whereas the lateral fibers go uncrossed. So both the medial fibers are damaged if you have any lesion at the optic chiasm. If medial fibers are cut, do you remember this concept? There is a complete crossing over in the eye. For example, if you take my right eye, for my right eye, now this pencil is on the temporal or lateral half of my right eye. But the image of this pencil will cross and fall on the medial half of my retina. It is not falling on the same side, it is falling on the medial half. When the pencil is on the medial half, it will cross and fall. The image will fall on the lateral half of the retina. When the pencil is on top, the image will cross and fall on the inferior half of the retina. When the pencil is down, the image will cross and fall on the superior half of the retina. So there is a complete crossing over. And because of this, if both the eyes' medial fibers are cut, in both the eyes, the patient would lose the temporal side vision. That is called lateral vision is lost. And we have exactly mentioned the same term in our class and notes. Optic chiasm lesion results in bitemporal hemianopia. In both the eyes, temporal vision is lost. Bitemporal hemianopia. And that's the correct answer to the question. So exact repeat from our class, bitemporal hemianopia. What about right and left homonymous hemianopia? Contralateral homonymous hemianopia, this can happen if there is any lesion in the optic tracts. If your right side optic tracts are cut, the patient will have left side contralateral homonymous hemianopia. If left optic tracts are cut, right half of the world you will not see. What about quadrant anopia? This is seen in lesions of optic radiation. If superior optic radiation is cut, inferior quadrant anopia. If inferior optic radiation is cut, superior quadrant anopia. So clearly the answer would be bitemporal hemianopia. Thank you so much for joining with me in this session on physiology. So this exam has told us that physiology is not a very difficult topic and the questions in physiology are also very direct and very simple. Little bit may be correlated with medicine. And if you have attended the classes, live classes, and if you have gone through the notes properly, every question, every single student would have answered in a very easy way. And thank you so much for that. We'll meet you in another session soon. Thank you.
Yeah, very lovely good evening to all of you. Well, is my screen visible and my sound audible? Am I audible?
Yes, ma'am.
Am I audible, guys?
Yeah, yes, ma'am. Yes, ma'am.
Okay. Yeah. Okay, fine. So, a very lovely good evening, first of all, to all of you. So, I won't take much of your time because, first of all, I would just like to know how your exam went. I will do the answers very quickly. And biochemistry, I am happy that this time my teaching was also justified because this time at least 6 questions were asked from the subject. Okay. So without wasting any time, let's see question number 1. Yeah. See, deficiency of which vitamin will cause this process to disrupt. Now, in this is a very common sense wala question. We know that whenever we talk about emulsification, okay, whenever we talk about emulsification, only one thing comes to our mind. Emulsification ke liye digestion of fats is there. And we all know that whenever we talk about fats, only the fat soluble vitamin will come into the picture. Only 4 options are there: vitamin A, C, B1 and B12. B1, B12, vitamin C, they all are water soluble. So their transportation is not required because they are water soluble. They are not stored in the body. It has to be vitamin A, as simple as that. And this is a very easy question. No, nothing, no hanky panky thing. Yes, fat soluble because emulsification is there and fat droplet is there. Right? Okay. Moving on to the second question. Now, if you beta look at the second question, so many times I have repeated this question in the class, so many times in fact. A 3-year-old child shows aggressive behavior, right, with self-mutilation with healed scabs on hands as shown in the image also. And if you people remember, I have showed you the image also. Which enzyme is deficient? Whenever we talk about aggressive behavior and self-mutilation, only one thing comes to our mind, that is Lesch-Nahan syndrome. So those students who have attended my classes, who have attended my PYQ session, yes, they have all must have done this question correctly. And this is a screenshot from my notes also. You guys can see Lesch-Nahan syndrome. Sabse important is, I told you it's an X-linked. That means it is present only in males. Yeah, self-mutilation, bite his own fingers and toes. And this is the picture which I have been sharing with you people so many times. Yes. Thank you so much. Beta, I told you na, ki this is the same picture which has been repeatedly asked in the exam. So I think without giving a second thought, you people would have gone for hypoxanthine guanine phosphoribosyl transferase. So this you all must have got right. Okay. So here the option is B. Very simple question, right? Moving on to the third question, which organelle is involved in packaging of secretory products? Now this is also a very simple question. Very simple, in fact, because we all know whenever we talk about basic things, whenever we talk about biochem, whenever we talk about physiology, we always discuss about, my classes were awesome. Thank you so much. The thing is that you people should score good in biochemistry because after a long time, I am seeing at least 6 questions from the subject. Okay. So packaging of secretory products, always remember what happens. Synthesis always takes place in the rough endoplasmic reticulum. Okay. Because the surface is rough. And whenever we talk about the packaging and sorting, it is the function of Golgi apparatus. Very basic question. Okay, isme bhi don't need any explanation because this is based on your class 11-12 ki knowledge also. You've been preparing it for NEET UG also, right? So it is A. Right, moving on to the next question. A factory worker presents with vomiting, watery diarrhea, abdominal pain. Yeah, the families in that region drink from groundwater supply. He is diagnosed with arsenite poisoning. Which step of TCA cycle is inhibited by arsenite? Thank you so much, Tommy Shelley, for the compliment. Yeah, okay. So here if we talk about, we all know arsenite is an inhibitor of inhibitor of alpha-ketoglutarate dehydrogenase. It is an inhibitor of PDH, and it inhibits one dehydrogenase enzyme also in glycolysis. Clear? Glycolysis we are not discussing. Link reaction we are not discussing. What we are discussing is TCA cycle. Again, a very simple question. Manu beta, it will be alpha-ketoglutarate to succinyl coenzyme A. This citrate and इसके लिए aconitase. Don't get confused between aconitase and arsenite. Aconitase, यहाँ पे the inhibitor will be fluorocitrate. Okay, because if we talk about, for example, if we talk about fluoroacetate, by mistake, if this fluoroacetate combines with acetyl coenzyme A, so it is going to form what? Fluorocitrate. It's clear. Fluoro will come like this. Acetate, oxaloacetate plus acetyl coenzyme, citric acid, right? So I told you that arsenite is an inhibitor of basically the dehydrogenases group of enzymes. Dehydrogenases 1, it is in glycolysis, it is ruled out. PDH, it's a link reaction because in the question it is clearly mentioned which step of TCA cycle. Again, there is no second thought for it. So again, this is a very simple question. You must have answered it correctly. Then coming over to this question, so many times I have repeatedly asked in the exam, told you in the exam about, this is actually phytanic acid. And I think by this time you people should have corrected it on your end also. Because beta, we all know this is a kind of recall session. So whatever questions are told by you people, we prepare that framework. So if you guys have any problem, if you think there were some other choices, so you are most, welcome to ask the questions and the options. Okay, so whenever we talk about phytanic acid, only one thing comes to our mind, alpha oxidation. And alpha oxidation, I told you, acha, mitochondria was there, not possible. Okay, because alpha oxidation mein, there are minor pathways and major pathways of oxidation. Beta oxidation remains the major pathway, alpha and omega oxidation remains the minor pathway. Okay, so where they are occurring? They are occurring in the peroxisomes. Okay, and obviously very long chain fatty acids are also oxidized in the peroxisomes. Correct, it's B. And deficiency of phytate oxidase leads to accumulation of phytanic acid, Refsum's disease. Even though beta Pallavi Golgi apparatus was not there, whatever may be the option, it is a clear-cut question whenever we talk about phytanic acid. I'll show you the screenshot also. Phytanic acid, you can see in the notes also. Phytanic acid, alpha phytate oxidase, if it is deficient, it will lead to accumulation of phytanic acid, leading to Refsum's disease. Right? And where it is occurring? It is occurring in the peroxisomes. Right? You can see that alpha oxidation is occurring in the peroxisome, most important one. Right? So it's clear? And I told you one more thing, phytanic acid is rich in, it is present in green leafy vegetables and goat's milk. If a person is consuming goat's milk and he complains of, a kind of diarrhea kind of thing, so that means phytanic acid enzyme is deficient, which is metabolizing. Okay. So here we can simply say the correct answer will be peroxisomes. As simple as that. Then moving on to the next question. A patient undergoes complete removal of pancreas and complains of steatorrhea. Which enzyme deficiency is involved? A very crystal clear question whenever we talk about pancreas. When we discussed about the diagnostic importance of enzymes, I told you pancreas may, whenever a person is suffering from acute pancreatitis, two enzymes will rise. Okay, amylase or lipase. That's it. Okay, so amylase and lipase, here they are talking about, again, some students might get confused between lipase and amylase because you might ask, ma'am, both enzymes are given. But here, complains of steatorrhea. What is steatorrhea? It is simply loss of fat in stool or feces. So obviously, when fat is there, it cannot be amylase. How can it be amylase? It has to be lipase. Correct? Yes, very good. So the answer is A. Clear? I think these are the 6 questions, yes. So this time we got 6 questions from Biochem, very simple, very crystal to the point questions. So I hope you guys did well in biochemistry. So I should be happy that way कि whatever I taught to you in the class was fruitful. बाल बाल बच गए. Okay, so all the questions were correctly done? Right. And still, if you guys have any doubts, because I told you better, this is a recall session. So recall, Acha, thank you so much, Dr. Kapil, for the compliment. Okay. So these are just a recall based questions. So if you guys still have any doubts, so you can just, tell us the doubts ki where something is missing or something has to be added up so that we can discuss them again. And if you got all the questions right from my end, so you people can just enjoy, keep your fingers crossed and wait for the result. Okay, you have been working hard for so long, so I hope the result should be good. So let's wind up the session. Thank you so much. Thank you for the compliment. You people made my day. I won't say day, evening now, because the day is going to end. Yeah. So I think after this, Dr. Srishti's session is there. Yeah. Thank you so much, beta. So wishing you all the best for your future. I hope you people clear the exam this time. Yeah. God bless you all. So now Dr. Srishti is going to start the session. Okay, bye-bye. Yeah, thank you.
So hello, good evening everyone. So I am here, okay, for your oral pathology recall. I am Dr. Shrishti. I think you guys know me pretty well. Now, with respect to, first of all, I always say in the class, when we talk about the recall session, okay, the recall session is very much important for the students who are going to appear. So I am who are going to appear in the next year, because this will tell you that we have done for the oral pathology. I think we have done our live class, and you also have got the recorded session. Okay, so this will boost your confidence, because by looking at the questions you will know that what, in a very concise form, what was exactly taught you in the class and how these questions they have appeared in your exam. Okay, now I would be very glad to know that how much satisfied you are with the oral pathology. I think majority of you would have attended my live class, right? So how satisfied you are with the oral pathology, that what we have done in the class, in the recorded or in your revision crash course and TND form, and how it was in your exam. So we have so many students with us right now. Okay, so can you guys just let me know how was oral pathology? Because what I have done, whatever I had taught in the class, okay, and the questions which was asked in the paper, okay, I have combined that and I have presented you all, okay, in that form, so that you will be able to correlate that what was the question asked in the exam and how we had taught in the your live class. Oral path was okay, ma'am. Whole paper was difficult. Yes, I'll be doing the answers very quickly. Okay, then just give me a second. Okay, now the first question, it was good. Okay, so the first question, patient complains of swelling on one side of the face. Okay, now if you guys will have Please fast. Okay, I'll be fast, okay, because I know that you guys are in hurry, that you just want to know the answer. Okay, now for all the students, okay, if you guys feel that there is some slight modification which is required in the question, so your suggestions are highly recommended. These questions are, you know, recalled by you all. Okay, so that is why moderate. I know the paper was slightly moderate. Now now chalo, let's start with the question. Patient complains of swelling on one side of the face with raised ear lobule as shown in the figure. Aspiration gives chocolate colored fluid. So this is a very easy and direct question. And there was a histopathology. What do we see? Biphasic pattern of papillary structures, bilayered oncocytic epithelium. Okay, so this is a Watten's tumor. I know you guys have been sitting for so long, 3 hours. Okay, but you know, I also have to see the students who are going to appear for the next year. Okay, so I cannot be this fast. Just bear little bit the way you have bear for the 3 hours. Okay. Now this is the Watten's tumor, which I have taken the screenshot of the notes. Now with respect to oral pathology, it was actually a 100% strike rate. Okay, so Watten's tumor. Now what is this? This is the basically the histopathology which I have mentioned is the bilayered papillary projections. Okay, so this is basically the papillary projection, and at the base of this, what do we see? Lots of lymphocytes, and hence it was very clear based on the histopath and also the clinical presentation which was given that there was a chocolate colored fluid. Now, a large swelling which is present on the hard palate. Histopathology with both myoepithelial and the ductal epithelium. Now, this, you know, now what they try to confuse based on this is the presence of pleomorphic. Now, pleomorphic adenoma also has myoepithelial and the ductal epithelial cells, but these are arranged in the cribriform pattern with the Swiss cheese pattern was also mentioned, and hence the answer is adenoid cystic carcinoma. So, what we have read in the class, so this was the actual image which was taught you in the class about the cribriform variant giving the Swiss cheese pattern. So this now when we interact in the live class, you guys always ask, ma'am, why we are only studying about the cribriform variant? Why we are not studying about the other pattern? Because that is why we cannot study whole of the oral pathology, because you have 18 or the 19 subjects to study, and that is why we compile all the important topics which will be going to ask in your exam. So this is the importance of reading in a very concise form, and this is our job to make it easy. Now this question we will discuss in the end. Okay. Now an HIV patient present with the red erythematous patches on the dorsal surface of the tongue. I think this was also discussed by me in your TND, and many times all these questions, they were discussed in the GTs and INIs. Okay, an HIV positive patient presented with the red. Now, for the students who are asking about the second question or the third question, kindly mention the question name, so it would be easier for me. Okay, so HIV patient presented with a red erythematous patch on the dorsal surface of the tongue, buccal mucosa and palate associated with the burning sensation. What is most likely diagnosis? Now, when we talk about the HIV patient, so the oral manifestation, now this was the chart which was given to you all in the notes, and it was taught in the live class. Okay, so the more lesions, so it is divided into 3 categories: lesions most commonly associated, lesion less commonly associated, and lesions seen only in the HIV. So coming to the candidiasis, so we have pseudomembranous and erythematous. Now when we talk about the pseudomembrane erythematous, it is associated with the burning sensation, and the candidiasis, okay, it is the most common presentation which is seen in the HIV. Hence the answer was very direct, it is erythematous candidiasis. Okay, now once you study whole of the 18 subject, then it becomes, you know, sometimes what happens that you get confused between the 2 options. Okay, and that is why whenever you are confused between the 2 options, just close your eyes and see what was taught in the See dear, I know you just want to know the answer, but when we talk about the live class, we have so many students, okay? A was not in the option because from the recall, what I have got, it was erythematous candidiasis. So if you have any suggestion, then please let me know. Okay, now the next question, now this question I'm seeing from, past 2 to 3 years. Okay, same kind of question but in a different form. Okay, no issues. Okay, A was the option. Okay, yes, A was there. Good, awesome. A woman presented with the blisters with vesicles in the lower lip and in conjunctiva. The histopathological feature shows the normal epithelium and the subepithelial split. Okay, the diagnosis. Now, as soon as they have mentioned there is a vesicle, bulla, and also present in the conjunctiva with the subepithelial split, that means they are talking about the mucous membrane pemphigoid, which is also called as cicatricial pemphigoid. So from last many years they are asking about the pemphigus vulgaris, but hence it was clearly discussed, okay, in the class about the bullous pemphigoid. I think you all have notes and you know this, okay. Cicatricial pemphigoid, that is benign mucous membrane pemphigoid. Ocular involvement is the most serious, and what do we see here? We see subbasilar split, okay. We see here subbasilar split. As the hemidesmosomes are attacked, we see subbasilar split, okay. Now again, the next question. It is a patient presented with expansile swelling on one side of the maxilla. OPG shows unilocular radiolucency with the deciduous canine in place and the lesion surrounding the CJ of an impacted maxillary canine. So, which is the most common developmental odontogenic cyst? Which is the most common? Vesicle in the skin was also mentioned. Okay, but vesicle in the skin, but if there is any vesicle which is present or any lesion which is present in the mucous membrane, that means they are specifically asking about the cicatricial pemphigoid. Okay. Now, which is the most common developmental odontogenic cyst? And which is the cyst which is associated with the impacted tooth? So, most common cyst associated with the impacted tooth, it is a dentigerous cyst. Now, one hallmark, now this, this I have shouted in the class, said that what is the hallmark for the dentigerous cyst, as they have clearly mentioned about the CEJ. Okay, so one hallmark, gross finding, that cystic lining will always be present at the CEJ, because here the source of the epithelium is reduced enamel epithelium, hence the attachment is present at the CJ. The question is very clear about the dentigerous cyst. Now there was a question which was asked about the dentigerous cyst in your last year also, but not this, based on the size of the radiolucency. So from this you can predict that the topics are much more commonly repeated rather than the questions, and hence these topics were well discussed in the class. Okay. Now, patient presented with central area of depapillation on the dorsal surface of the tongue and similar kind of lesion is present on the palate. What is the condition? What is the condition? Yes, CJ connection, dentigerous cyst. Awesome. Yes, I think we also have few students who are going to appear in the next coming paper. Okay, I think those students are answering this with lot of enthusiasm, right? So it is a very easy and direct question. Okay, rhomboid glossitis. Okay, and benign migratory glossitis. So students were confused between the rhomboid and benign migratory glossitis. Now when we talk about benign migratory glossitis, what is the other name? It is the geographic tongue. Kissing disease. Now kissing lesion is the other name of the rhomboid glossitis. Now this what they have given is the kissing disease, not the kissing lesion. Okay, so what is median rhomboid glossitis? It is also known as kissing lesion, and hence similar kind of lesion, it is present on the uvula or the soft palate just posterior to the dorsum surface of the tongue. Okay, so this was again a very easy and direct question. Now coming to this question, a patient, I know this they would not have given, so which is the answer? Answer is, you tell me. Answer is median rhomboid glossitis. They have not given the median rhomboid glossitis. Rhomboid, that means because of the rhomboid shape. A. Okay. Now, I know that they would not have exactly given you the exact same image, but even this radiograph is not there. Then also, I think you would be able to mark this answer based on the question what they have asked. Okay. So, patient presented with unerupted maxillary incisors. So, सबसे पहले तो it is present in the maxillary anterior region as shown on the image, radiographic examination. Now, multiple tooth-like structures were seen in the path of eruption. Now, when we talk about multiple tooth-like structure, that means these are multiple supernumerary teeth. So, hence a supernumerary, when we call multiple tooth-like structure, multiple supernumerary teeth, they are talking about the odontoma. So, which is the most common odontogenic tumor? It is odontoma. So, we have discussed this question in the class, okay, that there are two types of odontoma, compound and complex. So do not get confused between the compound and complex. Now when we talk about compound, it is present in the anterior region. So how we have learned in the class, posterior region is always very complex, and hence the complex odontome, it is more commonly seen in the posterior region. Compound odontome, it is more commonly seen in the anterior region. Okay, so this is the multiple tooth-like structure which is present in the anterior. Now, how compound odontome is different from the complex odontome? Okay, I'll mark all the questions. Okay, so here I have marked. Okay, I'll just go back, not to worry. Rhomboid glossitis, I have marked. Dentigerous cyst, I have marked. Okay, this is cicatricial pemphigoid. Erythematous candidiasis. This is adenoid cystic carcinoma. This is Wathin's tumor. Okay. Now coming to the next question. Okay. Now this question based just on the question what they have mentioned, okay, then also you can mark this answer very well, right, just by ruling out the option. A young girl presented with the yellowish discolored tooth since eruption. On examination, there is an enamel hypoplasia along with kinky hair and the brittle nails. Along with kinky hair and the brittle nails. What is the most likely diagnosis? Now, whenever we have 2 or 3, 4 clinical presentation, that means they are talking about the syndrome. Now, can you see in any option, in which option do you see there is a presence of syndrome? Even if you do not know what is trichodento-osseous syndrome, just by looking that there is a syndrome which is present, you can mark this answer right. Now, tricho matlab hair, right? That means kinky hair. Dento matlab there is some kind of dental anomaly which is present and the osseous defect. Okay. Amelogenesis imperfecta, as such there is no correlation with the kinky hair. Fluorosis has no correlation with the kinky hair or the brittle nails. Dentinogenesis imperfecta also has no relation with the kinky hair and the brittle nails. So there were many questions, I guess they were very direct, and just by ruling out the option you can mark this answer right. Now since we have done this trichodonto-osseous syndrome in the class also, okay, that means there is a presence of lot of impacted tooth, hypomineralized, that means there is an extreme severe enamel hypoplasia is present, taurodontism along with the tricho, that means kinky hair. Okay, so this was very well done in the class. Now coming to the next question. Okay, impacted teeth was not mentioned in the cyst question. Unerupted was given. In which question, dear? I think there were 2 questions which was from cyst. Okay, time to take next year's course. Yes. Patient complains of pain in the submandibular region during meals, which subsides eventually. Okay, now it is subsiding eventually. On palpation, there is a presence of hard mass which is present on the floor of the mouth. Now, whenever we talk about the presence of bony hard mass, okay, now based on the options you can rule out. Okay, dentigerous cyst. Okay, one second, I will go back. Dentigerous cyst. No worries. Okay, what was given, dear? Okay, unerupted tooth. The tooth has not erupted yet. That means it is impacted, right? Okay, there is a deciduous canine which is not erupted. Okay, even if it is that, but there is a radiolucency which is present, which is associated with that tooth. Okay, so whatever the presentation which is given in the question, based on that, dentigenesis is the best option. Impacted was mentioned. Okay, great. Chalo, impacted or unerupted, it actually does not matter. Main point you have to catch from the question that there is a presence of CJ which is associated with the lesion. Okay, with that, associated with that tooth. Hence the answer is dentigerous cyst around unerupted tooth. Okay. So coming to the next question. Okay, patient complains of pain in the submandibular region. Now, just based on, if you will start ruling out the option, you can come to the right answer here. Siloidinitis, it is the inflammation. Itis, that means it is the inflammation. Silolithiasis, submandibular gland neoplasm. Okay, submandibular gland neoplasm, submandibular region means there is a bony hard swelling. It cannot be submandibular gland neoplasm. Sclerosing siloidinitis. Itis, that means inflammation. Hence, it was a silolithiasis. So, silolithiasis on palpation. So, the main important feature, it is the bony hard swelling which is present on palpation, and hence we do bimanual kind of palpation. Hence, the answer is silolithiasis. Correct? C. Which question you are talking about? C. Trichodento-osseous syndrome. Now coming to the next question. Again, I hope this was the this I have got from you all based on the recall. Question 12B. Yes, silolithiasis. Correct. The child was brought with the lesion on the lower lip as shown in the image. The lesion shown below is caused by extravasation of the mucin into the adjacent soft tissue due to chronic lip biting. What is the condition? So we know mucocele is of two types: mucus extravasation and mucus retention. Extravasation, that means something which is going out, okay, because of the tear in the salivary gland or tear in the salivary duct, and hence it is called as a mucus escape phenomena. So they have also mentioned in the bracket, students, they have mentioned, ma'am, in the bracket they had mentioned mucus extravasation cyst, and hence the answer is mucus extravasation cyst, that is the mucocele. Now, which of these syndromes shows taurodontism? Okay. Now, I know this was the sequence, I think, which was discussed in the class, syndromes associated with the taurodontism. Now, whenever we have any doubt, as I always say, whenever you have to give the priority, okay, we always give priority which has been taught from the first number. Now, okay, so whenever we give priority, we give always priority to the first number. Now, it is very clearly mentioned in the Schaeffer's that most of the cases associated with the taurodontism, it is associated with the Klinefelter syndrome. So, we will always go by the book, and hence the answer was Klinefelter. Now, many students, they have marked it as a Down's syndrome. Okay, but if you have to choose between these two, now, if they would have given as an option both Klinefelter and Down, we could have gone with Klinefelter and Down. But if you have to choose, we will go with the Klinefelter. Now, if this was not the question, dear, then just please let me know. Okay, I will surely do the corrections. Okay, your suggestions are most welcomed. Okay, now this question, it was there. Okay, great. Now, this question I have not got the proper recall, but based on whatever the information which is given, okay, I will try to present you. A patient presented with a painless swelling in the anterior hard palate, okay, palatolabial region, as seen in the diagram. Now, diagnosis. Firstly, on the radiograph, they were able to see the radiolucency or not. There was a hard swelling or not. Now, the most common developmental non-odontogenic cyst. Most common developmental non-odontogenic cyst, it is a median anterior maxillary cyst, correct? Or also called as nasopalatine cyst. Now, what was discussed in the class, now based on that, we will mark this answer, okay? Nasopalatine cyst. Now, just give me a second. Yes, okay. Yes, nasopalatine cyst, okay. Given nasopalatine tooth was vital was mentioned. Now, even the tooth was vital. Now, the soft tissue counterpart of the nasopalatine cyst is what? It is incisive papillary cyst. Now, if it is present between the central incisor, then either your median anterior maxillary cyst, which is also called as nasopalatine cyst, and if it is a soft tissue present between central incisor, then it will go with the cyst of incisive papillary cyst, okay, which is also called as, now which is present between two maxillary central incisor. Now, burning sensation was also between central incisor. So now when we talk about nasolabial cyst, so we know that it is a soft tissue counterpart of the globulomaxillary cyst, which is present between, generally if it is present between the lateral incisors and the canine, okay. So with no radiographic, as associated tooth was vital, but there has to be some feature, ठीक है. Nasopalatine cyst है तो again if it is there is a, now if it is a nasolabial cyst, then what do we see? We see the nasolabial fold. There is a uplifting of the nasolabial fold, okay. So was two different question were there, okay. See, I think there is a no correlation as such. Burning sensation, then they are pointing towards the soft tissue part. That means it is present. Lamina dura was intact. Now, all the questions is done now. If you guys have any kind of between central and also a radio opacity was present, okay. So, if there is a radio opacity which is present and between central incisors, then short the answer is nasopalatine. There is no confusion. 7 mm was given. Okay, that means it is a clinical or radiographic. Clinical or radiograph. Radio opacity was there. Okay. So if radio opacity was there, then I think the answer should go with the nasopalatine, which is also called as median anterior maxillary cyst. Okay. So all the question with respect to oral pathology is done. So this is basically the students who are completely new, okay, who are going to appear for the next was mentioned recurrent swelling. Was there any kind of salty discharge? If there is a salty discharge, that means it is nasopalatine cyst. Any kind of clinical presentation? Bony swelling. So do you guys have anything which you want to? Okay, salty, awesome. Recurrent lesion. No radiograph. Okay. Salty discharge, if it was mentioned, then salty discharge was there. Okay, great. Then the question is very direct. Okay. Salty discharge. Nasopalatine, which is the most common. Chalo, even when you get sometimes when you are in a doubtful situation, I always say that go with the option based on the most common. So we know that most common non-odontogenic cyst, developmental non-odontogenic cyst, it is the nasopalatine or the median anterior maxillary cyst. Okay, so okay, this question I have not got. Okay, basal cell adenoma and no such discharge. If I have not mentioned any question, that means I have the diagram you have shown is wrong. Beta, I have got this diagram from the student. I have not created. I have not gone in the center to give the exam. Showing the okay, no issues. Okay, because different students, they are telling me golden heart syndrome question. I think that would have been discussed in your oral medicine and radiology. Okay. Okay, whatever the questions which is missed, okay, you can personally tag me on the Telegram group which is there. Okay, and I'll have a look. This was the question which I have received from you all and from the team. Okay. Forensic odontology, I think it would have been covered in your either oral medicine and radiology or in your pedo, I guess. Incremental line question, obviously it will go into the DADH, which is, yes, remaining. So if we conclude, so I think there was one question from saliva, two questions from the salivary gland. Okay. This is a viral infection. Adenoid cystic carcinoma हो गया बेटा, ठीक है? I think you have joint laid. You have joint laid. Okay. So there was two questions from the salivary gland, one question from the viral infection, and two questions from the cyst. Again, one question from the developmental anomaly, two questions from the tumor. So all these questions were asked from your most important topics, which I had, I think, shared with you all. I think SNI diagram with HNE stain, which will be taken in your DADH. Okay. Two questions on adenoid cystic carcinoma. Okay. Great. Okay, one histology diagram where I think they had mentioned about the Swiss cheese pattern. And the next question they had mentioned about the cribriform. Okay. So, if it is a cribriform variant, again, ma'am, there was one question on dense indentate. So, please let me know what was the question on dense indentate. Perineural spread, again, it is pointing towards the adenoid cystic carcinoma. If it is about the stage, I think there was a question maturation secretary that will be taken care in the dental anatomy and dental histology. Okay. Compound odontoma, that we have already done. Okay. So if any question is missed, you can please write down the question and just tag me in the Telegram group. I will have a look and I will tell you guys personally. Okay. I think cherubism wala question was discussed by Himani ma'am. Okay. Okay. So if you guys have any doubt, we can just wrap up the session. Yes. Yes, yes. Now you will have next subject. Yes, yes. Now we will have next subject. Okay, but I think there is a slight delay for the next faculty. So if you have any doubt and if okay, so the next subject is the anatomy. How compound odontoma differs from the complex. Okay, first of all, in the compound odontoma, it will look like a multiple tooth-like structure. But complex odontoma, it will not look like a tooth-like structure. That means there is a no differentiation between enamel, dentine. It is just a haphazardous arrangement of the cells, and also it is present towards the posterior region. So total we have discussed around 14 questions for the oral pathology. Cherry blossom appearance on the radiograph, Sjogren syndrome. I think it would have been done in your either oral surgery or the oral medicine and radiology. Okay. So if you have missed. Plexiform ameloblastoma. Okay. This I have not got, this question I have not got from you all. Okay. Dental material was done day before, it was done yesterday itself. Okay. So for the students who are going to appear in the next year, if you guys have anything to ask me, what should be the approach, okay, what time you should start your preparation, we all can help you with that. Golden hour syndrome. Yes, there was a question, but I think that question is being taken in the OMR. Brown's tumor. Yes, that was taken yesterday by Dr. Himani ma'am. Okay, so I'm taking a leave from you all and I wish you all bestest of luck. Do well in life, and if you guys have any query, you guys have all my number. You can just mention me in the Telegram group or you can just text me personally. So I wish you all bestest of luck. Stay in touch. Okay, chalo, bye-bye.
Yeah. Hello all. Am I visible? Okay. So I am visible. We can start the session. We can discuss the anatomy questions now. Okay, dear. Okay, so let's start with the session. So first thing is that all of you can have a live discussion along with me. I think, how was the anatomy paper? Please write on. Good evening. Yes, good evening, Vidushu. Good evening, Shruti. Good evening, all. Good evening, Saurabh. So I think anatomy was easy, moderate, or hard. Good. Okay, anatomy was good. So I think all the questions were from the notes only. We have discussed it all, and anatomy was very easy, I think. And I think most of you have solved it right. Easy, yeah. So I'm very happy to hear the word easy. Anatomy easy tha. तो बहुत अच्छी बात है. चलो, let's start with all the MCQs and discuss this together. Was good. Overall, the paper was tough. Okay, mixed. Many of the students are telling anatomy easy hai, the paper easy hai. कुछ बच्चे बोल रहे हैं थोड़ा tough है. Okay. So एक MCQ था. Okay, silly mistake. Don't worry about it. Let's discuss it. So बच्चे एक question ये था. Identify the structure. Arrow mark structure. Arrows ऐसे दिए हुए थे और ऐसे arrow mark structure था जहाँ पे bunch of nerves था. वहां आपको identify करना था. So you have to identify this, whether it is a lumbar segment of spinal cord, dorsal root ganglia, phylum terminal, and coda equina. So what is the Okay, so what was the right answer, dear? Right answer क्या आपने माना? Right answer दिया है. It is coda equina. Absolutely correct. Vashu, absolutely correct. Revolt, yes, it is coda equina. Absolutely right answer, dear. It is coda equina. The bunch of nerves. So we know that spinal cord ends at conus medullaris. That is known to us. And I think we have discussed about the ending point of spinal cord. And I have told you that the lower segment of spinal cord, where we have got bunch of nerves, that is called as coda equina. So coda equina is formed by the bunch of four lumbar nerves, all the sacral nerves. So all the sacral nerves and four lumbar nerves and one pair of coccygeal nerves. Okay, so obviously horse tail ki tarah hai. Yes, obviously it's like a horse tail. So definitely the right answer is coda equina. And I think most of you have marked it right. Okay. Now there was one question which was actually this is a question of histology part. So actually you have to identify the arrow marked structure. So basically जब मैंने bone बताया था तो many times I have told you about Haverian canal. Can you see this gold structures? What is this all rounded structures in the middle? So this is a transverse section. This is a section of, this is Haverian canal. This is Haverian canal, but the arrow was not over Haverian canal. The arrow was over the connection of two Haverian canal, and the two Haverian canal is connected by Volkmann's canal. Volkmann canal. So basically the right answer is A, Volkmann canal. Again, it's many of the students have given the right answer. Obviously, this was also taught in the, this was also explained in the classes and in the notes also in the histology part. We have seen the section of bone where we can tell that Volkmann canal is the connecting link between the two Haverian canals. And this entire one unit, which is having Haverian canal in the center with concentric laminas containing osteocytes, is actually one osteon or Haverian system. So this one rounded structure overall together is called as Haverian system. So I think all of you must have marked it right. So see here, I am again showing you, this is VC. What do you mean by VC? Have Volkmann canal, and HC means Haverian canal. Okay. So more images, actually these all images was discussed in the session also. And you can see, so sorry, you can obviously appreciate here that this whole one unit where you can see Haverian canal in the center having concentric laminas which contains osteocytes, osteocyte cells, and they communicate, they are located in lacuna, and this one unit is called as Haverian system, called as osteon. So obviously right answer. And this is the connecting link. Can you see this? The connecting link between the Haverian canals are called as Volkmann canal, obviously. So that is obviously right. This is again a Haverian canal showing osteocytes. So we have got the right answer. Yes, absolutely right. Here you can see the enlarged view of the image. which is showing you the Haveration canal in the center and the connecting link is the Boltzmann canal. I think most of you have marked it right. Okay. जिसने भी Boltzmann canal mark किया है वो absolutely right. Obviously, there is nothing to get confused. So many times you must have seen the Haveration canal in the center and the Haveration canal is connected by Boltzmann canal. Now let's move on to the next MCQ. Question number 3. Okay, this was a good question which has been asked. Which of these is the landmark which is used for identification of facial nerve as it exits from the stylomastoid foramen? Actually, this is the question about facial nerve. And in the classes, so many times I have discussed the facial nerve and we have talked about the branches of facial nerve and about the course of facial nerve, which we have already discussed. So facial nerve is related, as we know, it is the correct identifying point. So what you have marked, the correct answer will be in relation to posterior belly of digastric. So it is antero-superior aspect of posterior belly of digastric and just as inserts posterior to the foramen. So yes, A is absolute. So again, many of the students has given the right answer. So actually this we have done in the notes and you can see images of the notes has been also included. We have discussed this. Actually, facial nerve is passing through a stylomastoid foramen, gives innervation to stylohyoid posterior belly of digastric. So exactly the location when it exits from stylomastoid foramen and it is in relation to antero-superior insertion of posterior belly of digastric, that point is considered as the identification or the facial trunk identification landmark. So that is the right answer. Okay, got it? So you can, I just want you to show this. This image also is taken from the class notes and you can see this is the facial nerve in the facial canal and this is where it is actually emerging out. You can see this, this is emerging out from the stylomastoid foramen. And here itself, you can see it is related with the posterior belly of digastric. So obviously the right answer will be in relation to posterior belly of digastric. We can facial nerve roughly 1 centimeter superior above the posterior belly of digastric is the landmark where it can be identified. Now, a patient presents with absence of thymus. Actually, this 100% students must have marked it right because this was multiple times seen in the multiple times we have solved, and this is a very direct question from the previous year question papers. So a patient with an absence of thymus gland and inferior parathyroid gland, which of the following embryological structure is causing the defect? Yes, I'm going fast. I can understand you are very fast. No, the right answer is thymus and inferior parathyroid gland. So which, yes, C, third pharyngeal pouch. Yes, dear, third pharyngeal pouch is right. So ये वाला तो सबने सही किया है ना? This one is the right one we have discussed. Yes, C. So again, this is the image taken from your notes. So this is the image from the MDS note and you can see this is the third pharyngeal pouch. Inferior parathyroid gland and thymus gland is derived from the third pharyngeal pouch. Okay? Yes. So this, all of you have done it right because we have done it so many times. Now coming to a next question. Actually, this was another question. Question number 5. A child has defect in conductive hearing loss where incus of the ear was found to be absent. Okay. Where incus of ear was found to, which of these anatomical structure is involved in this case? So this is the question number 5. Question number 5. So what is the right answer? What you have marked? This is the easy one. This is absolutely easy one because you have to know from which pharyngeal arch is the incus derived. So what you have marked it? First pharyngeal arch is absolutely right. Yes, we know incus and malleus. So this is also pharyngeal arch derivative. It is first pharyngeal arch. So that is the right answer. Yes, no explanation. So again, I am showing you the notes which is taken from the class notes. It is already taught in the class. Now no explanation. Okay, you are knowing it. So they don't require explanation. Coming to 6th question. Congenitally deaf child defect happens in which of the following arch? Congenitally deaf child defect happens in which of the following? Actually, this was slightly confusing because exactly which part is involved is not mentioned. By either you can go for the first, second, both. So actually in this case, question number 6, all of you please go to question number 6. Actually here both first and second arch should be the right answer, both first and second arch, because we know that developing from the first and second arch. So first and second arch both should be the right answer. But actually, if we have to go with one, so we know that first arch is forming malus, incus, second arch is forming the stapes. But the defect of the ear, if then also we have to choose one. If both options are there and we have to choose one, we know that defect of ear is more related to the dysfunctioning of stapes. And so exactly this ossical defect, we will choose stapes and then we will go with second arch as the right answer. Got it? Second arch, then we can go with second arch as the right answer. Yes. Yes, actually, yeah, this is slightly confusing because first and second is both, but as we see that ear defect is more related to stapes dysfunction, so we'll go with second arch. Now coming to next, if tympanic plex injury is there, question number 7. If tympanic plex injury occurs, so what will happen? If the tympanic plexus are involved, what will happen? Okay, so whether the parotid secretion is less, facial nerve affected, lacrimation. So we know that tympanic plexus is related with the secretomotor fibers. With the secretory loss of parotid gland should be the right answer. Why? A. So please mark the right answer. What you have marked? Okay. Okay, no worries. Please help us to target the right framing of the question. Okay. Okay, dear. So, yes, A is the right because parotid secretion will be affected, because when I am talking about the primary secretory loss, we know that the tympanic preganglionic, we have got exactly the relation to otic ganglion, and we know glossopharyngeal nerve is involved, and that is the secretion will be affected. Lacrimation, submandibular, all facial nerve is involved. Facial nerve effect is not here. Here we have got the involvement of tympanic nerve plexus, which is actually, if I talk about parotid secretion, tympanic nerve carries preganglionic parasympathetic fibers via glossopharyngeal nerve fibers relay in otic ganglion, and this will lead to the loss of secretion from parotid gland. Okay, no explanation, you already know. I have taken this notes from the sessions, from the classes. These are all has been done in the class. Now this is a video question. Okay, this is the video question. Yes, the paper looked tough, but it was the paper looked easy, but it is tough. Okay, so watch the video and mark the nerve paralyzed. So for this, I want you to show the video. All of you just see here. I want you to show the video. Just a minute. Okay, you can see this. Yeah. So exactly now I want you to show the videos. Okay. Wait a minute. Can you see this video? Can you see this video? So see here. This was exactly the video formed. Okay, so all of you have seen the video. Now mark the right answer. Which nerve is involved? Lingual. So see the question number 8. What you have marked? Now question number 8. What you have marked? Buccal branch of trigeminal, lingual nerve, labial nerve, or buccal branch of facial nerve. What you have marked? What you have marked here? So the right answer will be the buccal branch of facial nerve. We know that the buccal branch of facial nerve supplies the muscles here: buccinator muscle, zygomaticus major, minor, orbicularis, oris, levator labile superioris, and the action which was done was actually the due to this action which is seen here, the buccal branch of facial nerve is injured, which can result due to surgery or trauma, and this lead to drooping of smile and inability to puff the cheeks because the muscles around the oral orifice is affected, mainly the buccinator muscle, which is causing cheek compression, the orbicularis oris movement, zygomaticus major minor. So the right answer is buccal branch of facial nerve. The right answer is buccal branch of facial nerve. Is it okay? Everyone has marked this buccal branch of facial nerve? Any doubt? Let me just check with the students. Yes, this is Himani ma'am. Yes, this is Himani ma'am. See, so really incredible work. She has exactly performed the same as the video which has come for the examination, and exactly this was exactly, yes, this is the buccal branch of facial nerve. Yes, you're right. So it can be other buccal branch of trigeminal, sensory, lingual also not, labile also not. So buccal branch of facial nerve. Yes. I'm not going into further explanation because students have already told me that we are understanding it. They just want a correct answer. Thank God something is right. Yes. No, dear. Now coming to the next, this I think this is 100% right from you all. During posterior neck dissection, a surgeon incised longus capitis and the rectus capitis muscle. Post-operatively, the patient loses sensation over the angle of mandible. And my dear students, number of times we have discussed in our lecture class also, only the area which is close to the angle of mandible in whole area of the face is supplied by trigeminal. This area is supplied by great auricular nerve. Okay, so this was cervical. Yeah. Okay. It will be facial nerve. It will be facial nerve for the previous one. Okay, hurry. It will be facial nerve. Yes, A. So all of you have given absolutely right answer. This is the great auricular nerve. Yes, absolutely right answer. Great auricular nerve. Great auricular nerve is absolutely right. 9 questions done. 9 questions done, Man. Man, we have completed 9 questions. So yes, this is again, I am showing you the image from the notes, and you can see this is the image taken from the notes. Great auricular nerve is getting innervation through the close to the angle of mandible. Now, pariform fossa, sensory supply. So this also we have done in our lecture classes. This also we have done in our lecture classes. Pariform fossa surgery, sensory supply of larynx is lost. So which nerve is affected? Which nerve is affected? Yes, great auricular nerve is absolutely right. Absolutely right. So this is again very internal laryngeal nerve, and we have discussed about pariform sinus fossa, boundaries and injury, and we have discussed so many times in the examination. The right answer is internal laryngeal nerve. So again, many of the students has marked it right. Actually, this is easy direct from the previous year MCQs also. This is again the image taken from class notes, which we have discussed. Internal laryngeal nerve, as you can see, this is piriform recessus. That is the additional secondary food channel, smuggler fossa, where we have got internal laryngeal nerve as the innervation source. Internal laryngeal nerve. Yes, internal laryngeal nerve, branch of superior laryngeal nerve. It's internal laryngeal will give the sensory innervation. External laryngeal nerve will give innervation to cricothyroid. And recurrent laryngeal nerve will give sensory innervation to the lower laryngeal cavity. So here, internal laryngeal nerve is the right answer. Okay, now coming to ma'am, will this be available in the live DBMCI? This will, yes, this will be present there. Yes, this will be present there. A 70-year-old male is unable to perform learned skill movement. Skilled movement learned. So sensory function. What do you have marked it? Skilled, learned skill movements. Learned skilled movements. So that is the keyword which is mentioned. And you have to give me the right answer. So the right answer will be premotor area. Actually, when we are talking about the 70-year-old male who has actually unable to perform learned skill movement, means that skilled purposeful movement, this condition is called as apraxia. And despite having its normal sensory and the motor control, this will be actually, this condition particularly is to not able to perform the learned skill tasks to be performed. The area involved is premotor area, that is area number 6. Area number 6. Is it okay? Yes, absolutely correct. Yes, that is coming, dear. That is coming. Yes, absolutely correct. So again, now coming to question number 12. So this is number of times done. A patient with head injury, with road traffic accident is diagnosed with extradural epidural hemorrhage. Okay. Yes, I will come to that hemi-mandibulectomy question also. That was also slightly confused. I will come to that. Don't worry. A patient presents with head injury, road traffic accident, diagnosed with extradural epidural hemorrhage. And which area is involved? Terion. So number of times this H-shaped suture is involved. And you know that the right answer will be bleeding from middle meningeal artery. That is the frontal trunk of middle. So this is a direct repeat from the previous year question. This is a direct repeat from previous year questions. Number of times we have discussed it. And I think 100% right answers must be getting from all of the students. And I can see everyone has marked it. You can see we have discussed this. This is the image taken from our notes. We have already discussed this in the previous year's session. Yeah, thank you, dear. Thank you, dear. Yes, we have discussed this. I have shown you this image also and the middle meningeal artery relation to terion. Now, this is an easy one. This is a direct question from lymphatic drainage, palatine tonsil drainage. Palatine tonsil drainage. Palatine tonsil is draining mainly to which of the following group of lymph nodes? Jugulodigastric, jugulo-omohyoid, submental, parotid. So what is the right answer? So the right answer is jugulodigastric. What is the right answer? A. Again, my dear students are giving the right answer. Yes, jugulodigastric is right. Yes, A is absolutely right, jugulodigastric. Yes, it's absolutely right. Everybody has marked it right. Now, so I'm not going into explanation. This was direct question. We know that palatine tonsil is primarily drained from jugulodigastric, ultimately drains to deep cervical lymph node. Now, this is the question which so many students got confused, and because there are two answers which seems to be correct, but we have to choose one most correct after hemi-mandibulectomy. Okay, question number 14. So after mandibulectomy, a patient has mandibular deviation. So which muscle is affected? Which muscle is affected? And you have to mark the right answer. Actually, here medial pterygoid, lateral pterygoid, both seems to right answer. But if both in the option, the primary muscles to be involved will be A, lateral pterygoid. What will be the right answer? Lateral pterygoid. Actually, the unopposed action of. So if I'm talking about unopposed, so lateral pterygoid is involved in the contralateral protrusion. So lateral pterygoid is primarily responsible for protrusion, and the loss of resection and unopposed action of the other side of lateral pterygoid muscle will lead to this mandibular deviation. Actually, few get confused with medial pterygoid. Medial pterygoid is also has a got a. But if we have to choose the primary one is the lateral pterygoid. So we will mark lateral pterygoid as the right answer according to its action. So we will pick. Okay. Okay, lateral pterygoid, because I think it is having the primary. Lateral pterygoid muscle is primarily responsible for the, I told you both are correct. Lateral and medial pterygoid both are correct, but exactly the lateral pterygoid is only responsible for contralateral protrusion, as lateral pterygoid has got a primary action of protrusion. So we will mark lateral pterygoid as the better answer. Okay, as the better answer. Is it okay? Many of the students has marked it as A. Okay. So basically, it protrude and deviates the mandible to the contralateral side and result in loss. The outcome will be the jaw deviates to the operated side. This is the correct explanation to the question. Is it correct? So we have done with, you have marked many of the answers right, and we are hoping for a good result from all of you. Is it okay? We are hoping a good result from all of you. Okay, so all the best, and all the best, and we will have the discussion of next subject. Is it okay? Yes, it's we have discussed with the other students also. They were also confused about this medial and lateral pterygoid. Okay. 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 So now I think Dr. Dhruti Modi ma'am will start the session. Is it okay? Okay. Thank you. Okay. Start the session. Is it okay?
Yes,
Thank
ma'am.
you.
Yeah. Okay.
Okay.
Yes. Okay. Hello, dear students. Myself, Dr. Dhruti Modi, and now we are at the end of the session, and this is our last subject. All right. I know you guys had a long day. These 2 days and 3 days were very, very hectic for you. Okay, so we'll be just looking into our DADH questions. Fine. We'll be finding out those answers, and then we'll be ending this today's session. Fine. So let's begin. There were total 14 questions from your dental anatomy and dental histology. Most of them were like little easier only. Few of them were easy. Just one or two of them were a little tricky. Okay, I have my YouTube chat on over here, so I can see that. Fine. So the first question, is that the maxillary molar is the largest tooth which has 4 cusps. One cusp which is an accessory cusp. Where is it present? I know it was a very, very simple question. Fine. So in this, you know that your answer, which cusp is it, guys? Okay, I can see people are answering me on that. Okay, so you know that the answer for this is your mesiolingual cusp. Fine. All right. Now see in the, yes, this is DADH going on, students. I want you all just to have a little bit attention over here. Fine. And as we have explained to you guys multiple times, it was a very simple question. Okay, so on which cusp of cerebelli is present, you know that is the mesiolingual cusp. Okay, and this is a very basic question. Fine. And in our notes also we have highlighted it multiple times, telling you how this molar tooth is very, very important and we need to know about it, right? So this was the first. I'm pretty sure most of you have got this right. Fine. Let's move to the second question. Now, maxillary first premolar for the right and left side can be differentiated by what feature? Okay, they have asked it in a very, very simple format. They are just asking us what is the characteristic feature of the maxillary first premolar. Now, when you see first answer, the first option, buccal cusp is larger than the lingual cusp. We know that is not the feature of a maxillary premolar. That is the feature of a mandibular first premolar. All right, fine. The buccal and the lingual roots, of course, that does not help us to differentiate between whether it is a right or a left. So then we know that the mesial marginal groove and the developmental groove, it is a characteristic feature of your maxillary first premolar. I'm pretty sure all of you know this part. Yes. Fine, as we have always highlighted how it is a very, very important MCQ and it has been asked multiple times. Okay, so it is favorite for them to change the topic and then ask into that format, little twisted, and then you can understand. If it's on the mesial side, you know that will help us to identify whether it's a right side or a left side. Yes. Okay. Now let's come to the third question. Diamond shaped groove is seen on which teeth? This one was a little bit of a tricky one because as they are asking about the diamond shaped groove, so basically they are trying to ask about the wear facet which is given. All right. So in this, it was very easy for us to identify first the tooth only in itself, that whether it's a canine. Fine. So automatically it is eliminating the lateral and the central for us. So now when we see that whether it can be a maxillary or mandibular canine, it can be a little tricky for you. Okay. So in this case, in such scenario, why it is called as diamond? Okay, the diamond shape is because of the tooth. All right, it is because of the tooth. So in this, whenever you see the mesiodistal width of your maxillary canine, it is more than the buccolingual width of your maxillary canine. So for that reason, you see that diamond shape of wear facet. All right, so for that reason, your answer in this is maxillary canine. Okay, I feel most of you might have marked it a little different because it was a little confusing whether it can be maxillary or mandibular. Fine. Yeah, many of you have marked it B, but the correct answer is maxillary canine. The diamond word, it was given specifically so that you can identify it. Okay, whether it will be maxillary or mandibular. Fine. Now we are moving to the fourth question. The distal surface of maxillary and mandibular molar are in the same plane. Fine, this was important to see. Okay. What kind of relation is this and what might it further transform to? Fine. So when I'm saying distal surface of maxilla are in the same plane, we automatically know that they're talking about the flush terminal plane. All right. So automatically it is eliminating the mesial step. For that, we know that if it's a mesial step, the distal surface of your mandibular molar is going to be ahead of your maxillary molar. So automatically these two are eliminated. And of course, the distal step means the distal surface of your mandibular molar will be behind your maxillary molar. So it was also a very, very easy question. Fine. For now, we saw 4 questions. 3 of them were really easy. Only the one question which was tricky was the third one. Okay. See, now in our notes also, we have always highlighted this very much pretty. This question has been given and we have given a proper picture to you. Fine, so that you can see that how flush terminal is present end on end, and we see a distal step over here, and in this we see a mesial step, and we also know that what it is developing into, either into end on position or into the class 1. Fine, so they had not put much trick into this because the mesial step they had given into 2 options. So if you were able to identify flush terminal, it was very easy. Yes. Okay, the 5th question, this one was a little bit of a brainer. Okay, so if cervical prominence is reduced, further it can cause what? So now we know that they're talking, see, they have given this arrows very easily, beautifully for us to understand that what they're trying to ask. Okay, if they've given this arrows, it is to show you that there is this height of contour. Okay, so because of this, if I'm reducing it, what happens? The arrow, if those of you who were able to identify this arrow would have been able to answer it. Okay, many of you, I'm getting the correct answer from this. All right. So see, first improve the aesthetic. No, it is not going to improve the aesthetic if it is in that. Firstly, it is in the molar, so it is not going to play any role in that. Fine. Okay, improve the occlusal stability. Something out of the buccal surface is not going to help you with the occlusal stability. It is the occlusal surface which plays a role into it. So, as you can see the arrows, it is your food impaction and gingivitis. So, your cervical, the whatever height of contour is there, it basically flushes out your food. Okay, it does not let it get dislodged into that area. Okay, because of that, there is no food impaction, and as there is no food impaction, your gingiva doesn't get affected, and as gingiva doesn't get affected, you don't get gingivitis. So that is the function of your height of contour, what you have. Okay, the prominence which you are having into this region. So I believe most of you, yes, self-cleansing, many of you have got it right. Okay, fine. See, now let's move to the 6th question. A developmental disturbance is seen in the morphology of the tooth. Okay. Further, the dentist got gene mapping done. With this revealed an issue in the cell signaling. This was a key term which was given for you so that you could not have any confusion into answering this. Okay. So, Because of this, which structure would be responsible for the same? You know that HERS is for your root formation, all right? So it is not playing any role into your signaling, and they have identified as morphology. So in this, of course, at times they try to give very, very simple option. They could have confused you very easily by giving enamel knot, cord, niche and all. But no, they instead gave you cervical loop. You know that the cervical loop is the transient extension of your, the HERS is the transient extension of your cervical loop. So automatically these two are out. And you know the dental lamina is the precursor for your tooth bud development. So your answer over here is enamel knot. Okay. Very, very simple question. Most of you, I'm pretty sure you would have got it right. Yes, correct. Good. Many I can see that have marked the answer correct. Fine. So see, in our notes also, we have highlighted it very beautifully. What are the function of your enamel knots? Okay. And what it comes as an MCQ. And the same term had come as an MCQ. It's a signaling center. Fine. Yes. Okay, this one was a little tricky one because they asked about a gene. Okay, first of all, oligodontia. You know that oligodontia is missing of 6 or more teeth. That is your oligodontia. All right. So now which gene is missing its expression over here? So you have been taught about these all kind of genes, right? You know that the PAX gene is there. What it is doing, it is determining the position. All right. So now they have pretty much made it clear that these are multiple options which have been given. In this, the PAX9 is repeated multiple times. So now from this, many of you would have been able to make it out that this is the answer. This one is automatically rejected. Confusion can come into these two and of course this. But I can see many of you have answered it correctly. Yes, it is C. It is a simple theoretical question which has been asked objectively. Okay, in this there is no subjectivity, nothing. Fine, we know that the MSX1 is for your determination of the position of your ectomesenchyme and epithelium. Many of you would have gotten confused between DLX and MSX, but I can see in my chat that many of you have answered it correctly. Fine. So till now, what I was able to make out that DADH was actually very simple. The questions were very, very objective. Nothing controversial or tricky was there into this. Okay, till now. Many of you in this, I have a feeling that you might have got it wrong because it has little confusing description. Okay, a thin chipping enamel. First they give you that and then they tell that it is discoloring. So which of the stage in amelogenesis is affected? So many of you might have gotten confused between A and B. Fine. So see, secretory stage, we are automatically eliminating this because we know that in this the matrix is affected. When your matrix is affected, you know that that appears into the pitting format. Okay, and there is a luster which is present onto your enamel. Fine, and you don't see chipping. You just see those scaffold, that dots pits like in that which is present. So hence this gets eliminated automatically. Organizing stage, you know, it is the initial stage of your ameloblast. So this is also not there. Now comes your maturation and your mineralization stage. You know that your matrix gets laid down. After that, your mineralization occurs. When then mineralization has occurred, there is maturation basically. Okay, in your mineralization, your crystals, they are starting to enucleate, and in your maturation, they all start to grow together. Fine. So now, to clear your confusion, I've got these lines from Orban. Okay, what does they say? The hypocalcified soft enamel matrix is soon discolored and abraded. So, an injury during the maturation stage will cause deficiency into this calcification. Fine. So now from that you understood that they're talking about the maturation stage which is causing this issue. It is not the mineralization stage. Fine. I can see multiple of you have answered it correctly. Okay. Yes. Fine. Now let's come to the 9th question. A patient underwent trauma and later after some day, a radiographic change was visible in the apical border. As always, we are supposed to mark the keywords, okay, which was radiolucent, and this word was specifically used, ragged borders, okay. So from this, I know many of you can make the diagnosis very easily. First of all, it is telling that it is in the apical border of the root. So that automatically tells that it is not going to be the caries. Okay, due to trauma, you know caries can't occur into the apical border region. Fine. Cementum hypoplasia. It is something basically due to a long-standing chronic infection that causes the cementum to overgrow. So that is also not going to be there. It said that it had radiolucent border, means it is something in regards to the resorption. So now it is telling in resorption. So they gave a characteristic feature, ragged borders. Okay. So this ragged border means that it is in an external manifestation. If it was an internal manifestation, it would have been from pulp to cementum and it would have looked smoother. Fine. So the answer for this is A. Yes, many of you have answered it correctly over here. Okay. Now this was very, very sort of different this time, as they had given a hand-drawn image. Okay. So in this hand-drawn image, firstly, they were trying to ask us to identify that which kind of SNI this is. And from this SNI, they were trying to ask us to identify the gland. Okay. But the features were given. It is, the image shows minor salivary gland cells which prepares the papilla for taste perception. When I say papilla, okay, it should come to your mind that they're talking about something, some gland on the tongue. All right. And further clearing the space for receiving the chemical mediators for taste. Okay. Now, when I'm telling tongue, so automatically these two are the ones which are eliminated. All right. And the gland of Baldwin and New. Okay, so from here is what we have to identify, that whether they're talking about this or this. So the image was for that. In this, you can see that the SNI which are given are your series. You can see that they are pyramidal over here. All right. So an easy answer was this for is gland of von Ebner. See, we have very, very specifically always told you that this gland is very important, okay, because this plays and opens into your foliate papilla, into your circumvallate papilla, and how it helps into clearing those troughs, okay, with that saliva, and then hence the taste perception can be done easily. Fine, many of you have answered it correctly. Perfect, guys. Okay. This question, radix paramolaris. Okay. Now this they have not yet asked. Now, usually they ask about distomolar or paramolar. This was a new one, a different one, because they were coming in terms of the root. So this is again a very, very objective question. Okay. In this, it is not an extramesial or a distal root. Okay. It is a buccal root which is present under the buccal surface. Either it is always buccal or it is a mesiobuccal. Fine, so this was C. I believe many of you were a little confused while answering this question, okay? But the answer for this is C. Fine, guys? Okay. Now we are almost going towards the end. Fine. In the forensic odontology, okay, incremental lines which are used for age estimation. Okay, very, very good way of asking you about the incremental lines, whether dentine, enamel or cementum. Okay, so age estimation, in this which lines are used? Okay, you know enamel is the one which is on the outer surface, it gets worn off with time. So this cannot be used for that. Pulp does not have any incremental lines. Then is your option is dentine. Dentine is something which is repairing, forming, and of course it is in the reactionary phase. So over here we do not see any, that form of incremental line which will help us to do age estimation. Okay, so cementum line are the ones which help us in doing age estimation. Okay, because there is a very systematic placement of those increments into your root. Okay, so that cementum line always helps us into the age estimation. Okay, many students, I'm pretty sure, yes. So yes, Kalima, you have written it correct. Krager and group, they have asked, yes. Correct, guys. So we have taught you that the incremental lines of Salter, the cementum, they are used for your age estimation because they have a proper increment. The number of increments, they tell us the age of the patient, fine, and from which we can determine and we can do the forensic odontology. All right. Yes, many of you have marked it correct. Yes, it was given Krager and group. Very nice, guys. Yeah. So till now, only 2 or 3 questions were tricky. Rest, all of them were very, very direct. And I'm pretty sure most of you have got it right. Okay. So if leeway space of Nance is not used, okay, and a spacing is present mesial to the molar, it will lead to what? This was a little bit of a brainer. Okay, so first thing which should come to your mind is that we know that the leeway space of Nance is the one which is used for your early mesial shift or late mesial shift. So when something is being asked in horizontal direction, so automatically it should help you all to answer this. Okay, Open bite, you know, open bite is something is in regards to your vertical dimensions. So if your molars are over erupting, or if your jaw is the one which is like the lower jaw is protruded, during that time you can have open bite. But leeway space of Nance, you know that it is something in regard to your horizontal space, so this automatically eliminates that. Increased vertical dimension, this is the one which is in the regards to your eruption of your permanent molars, that helps to open that deep overbite, overjet and overbite which we have. So of course it is not there. Confusion can have occurred in this one only, increased overjet or arch discrepancy. Fine. So increased overjet, that is, see, space of this leeway space of Nance, it is present in both, in upper also and in lower also. So for it to have an increased overjet, all right, the space needs to be like that, that it is covered for in upper and it is not covered in lower. But the diagram clearly mentioned that both of them are having that space. Now, when you see that space is not covered, okay, it will definitely cause crowding in your interiors, and there is going to be a discrepancy in your arch. Right? Yes. So many of you have answered it correctly. The D is the correct answer. All right, guys. So DADH was pretty easy, okay, and it had almost 14 questions, and only 2 to 3 of them I'm pretty sure you would have got little confused and might have left one of them. But overall, this was easy. I know the overall paper was tough. Do not worry, guys. Just have your hopes high. Okay, you never know what can it be. It was not only tough for you, it was tough for everybody. So those who have worked really hard, those who have clear concepts, they're definitely going to come out with flying colors. Just have faith in yourself. Just be optimistic. Okay. Do not go into that deep, that thinking, overthinking the loop. Do not get ahead of yourselves. Okay. Anything can happen. Just keep your hopes high. All right. And so now, guys, there is NEET 2027, okay, which is our next target, which is very, very important for us. So a new batch is starting on 9th May. Fine, and admissions are open. So you know that the USP, the important DBMCI perspective which we have is we have a schedule, okay, and you have all the live classes, recorded classes available to you. So you can watch them at any time you want, at your own feasibility. Those who are doing internship, okay, this is very, very important for you, and it's a very good plus point for you. Okay, you can watch at your own convenience, and of course it has multiple tests. Okay, to excel in anything we need test. Without that we cannot know and we cannot move ahead. Fine. And of course, after test, you have multiple doubts, because if you're testing your knowledge, you will definitely have a broad thinking. So for that, you have all our gurus available to you, okay, on Telegram also, and you can ask the sessions, doubts to them live also. So, and of course, there will be many issues in your life which you might be facing in day to day with preparing this, and of course you might get a little anxiety, you might not know what is coming next, right? So for that, a special session every day in the morning with Dr. Himani, we have daily mentorship, okay? So you can ask, you tell your day to day problem to her, and you can take proper guidance from her, and you cannot go off track even for a day. Fine. So I really hope that all of you did well in your papers. Do not worry about the hard part. Just wish for the best, all right? And those of the new students in the YouTube, just definitely look at this and then join the classes. And we have to definitely crack our 2027 MDS NEET. All right, guys? So, fine. Guys, I'll be ending this session, okay? I hope you all enjoyed this. I know it was a very, very tiring, long session for 2 days, but it is going to be amazing, guys. Fine? Okay, all right. Chill. Good night. Rest well, eat well, and just wait for the results. Be optimistic. Do not go into the negative loop.